My name is Robert Bissonnette. I'm a dermatologist from Montreal, Canada. I'm the current president of International Eczema Council. I'm very, very excited to be here this afternoon. This is a first for the International Eczema Council to partner with AAAAI to organize this course on atopic dermatitis. We have a fairly busy schedule, a very interesting number of presenters who are experts in their various fields on atopic dermatitis, and this course is about new developments in atopic dermatitis and implications for the atopic march. And now I'm learning how to, this doesn't work, this should work. Yes, it works, great. So as a reminder, we are recording this session. We always do this because after the meeting, we post it on our website for later on-demand viewing. And this is something that we started to do a number of years ago. And it's really good because the number of people that are viewing those sessions online is significantly higher than people coming to meetings and assisting in person. All right, so for those of you who are less familiar with IEC, IEC is a non-profit global organization that was founded in 2014 by Dr. Amy Powler and Emma Gutman. It's an organization that is open to dermatologists and allergists. We currently have a total of 124 counselors and associates, experts in atopic dermatitis from 28 different countries on 5 different regions. So even though the association is open to dermatologists and allergists, we have many dermatologists and not that many allergists. So if you sit in the room today and you're an allergist and you have a strong interest in atopic dermatitis, if you do research in atopic dermatitis or if you publish in atopic dermatitis, if you're interested to join IEC, please go to our website and make an application. We need more allergists. What's our mission? You don't have to read everything that is on this slide. We have a twofold mission. One part of our mission is geared towards education. Our mission is to educate, mostly physicians, on atopic dermatitis so that they can offer better care to patients. We also have a mission focused on research. We want to be able to facilitate atopic dermatitis research. How do we do this? We organize symposia, courses at various meetings. We've been present at dermatology meetings, local meetings, regional, international meetings. We're present at this allergy meeting today. We've been present at pediatric meetings in addition in the past. In addition, in terms of research, we offer research fellowships to allergists and dermatologists, recent graduates that are interested in atopic dermatitis research. And I'll talk about this in less than a minute. First, our disclosure. So as a nonprofit organization, in order to do all this, we need funding, and some of the funding comes from our industry partners that are on this slide. So in terms of symposia, we have many symposia that will take place this year. In addition to the symposium today, we will be at AAD, American Academy of Dermatology, in a month with a symposium about prurigo nodularis, which is often associated with atopic dermatitis. We'll be present at the International Society for Investigative Dermatology in Tokyo with a symposium on pathophysiology. RADLA, a meeting of dermatologists from Latin America. We'll be talking about atopic comorbidities in AD patients. World Congress of Dermatology, Singapore. This will be a well-attended event. Non-atopic challenges in atopic dermatitis patients. We'll be talking about pruritus at the European Academy of Dermatology and Venereology meeting. And finally, ISDS will have a symposium on basic research techniques in AD. In terms of research fellowships, we have one current opening, one open competition for research fellowships. So any allergist or dermatologist, recent graduate who would be interested in a one-year fellowship in research in atopic dermatitis, we have one program right now that is open for anybody around the world who would be interested to come and work with one of our Canadian counselors or associates. We published a number of manuscripts. Some of those manuscripts are review publications, some are position papers, some are based on some internal research that we've conducted. So if you're an IEC counselor and associate, you're in the room today and you have an idea for such a manuscript, please come to see me, come to see our CEO, Alan Stile, or anybody else within the organization. We have a research committee which will review these ideas and suggestions. And this is one of the advantages of being an allergist member of IEC. If you have ideas for a position paper or guidelines or important publications, it's something we can help you move forward. And finally, so our agenda today, our course moderator is Dr. Scher. She will be the one doing the talking this afternoon. We have two co-chairs, our two founding members, Dr. Amy Powler and Dr. Emma Gutman. We will talk about many things. We'll have a break because a 4-hour session without break, few people can be attentive until the end. After my talk, Dr. Silverberg will talk about differential diagnosis of atopic dermatitis. We have two pre-recorded talks today. So we have Dr. Gutman and Dr. Irvine, who unfortunately could not make it. Dr. Gutman will talk about immunopathogenesis. Dr. Irvine will talk about the barrier, his research specialty. Dr. Powler will talk about the clinical and molecular differences between children and adults in atopic dermatitis. Dr. Jack from Montreal will talk about infections and atopic dermatitis. Then we'll have a break. After the break, we talk about treatment and prevention. I'll be giving a talk on emerging topical therapies. Dr. Simpson will give a talk about emerging systemic therapies. I dreamt about him last night because we don't have anything personal together. Because yesterday he sent an email to all of us saying, I'm not sure with the weather I'll be able to make it. But he was able to make it. He's in the room, so everything is good. And finally, Dr. Agash will talk about the prevention strategies for atopic dermatitis and the atopic march. Now, to introduce, I don't know if she needs an introduction here, but to introduce our moderator this afternoon, Dr. Scher is a board-certified allergist and immunologist. She's a section chief of allergy and immunology at Monmouth Medical Center and a clinical assistant professor of medicine at Rutgers Robert Wood Johnson Medical School. She has been, this is interesting, she has been consistently selected by her peers as one of the top doctors in America in several publications, including Best Doctors in America. She's a practicing allergist. She has a private practice in Ocean, New Jersey, when she not only sees patients, but also heads up a clinical trial division. So she's active in clinical research. She probably will challenge some of my presentation this afternoon. She serves on several committees at AAAAI and is currently the chair of the Allergic Skin Disease Committee. You'll be able, if you're interested to learn more about all our presenters today, in the booklet that you received when you came in, there's more information. So some of them have fairly extensive bio in your booklets if you want to learn more. Dr. Scher.
Thank you. Thank you very much for coming to this session. I know it's going to prove to be a really insightful and exciting session, and we're so excited to be here presenting this to you. This has been over a year in the making. When the IEC first contacted the Allergic Skin Diseases Committee, they wanted to do something last year, and of course, you know how AAAAI programming works. That was not happening. Everything was already set in stone, and so we started putting this together for this year. And I think all of you know that these pre-sessions on a Thursday, usually they charge $200 or upwards to attend, and the IEC really wanted to sponsor this program and make it at a minimal cost to all of you. So I just wanted to mention that we're very thankful for their support in bringing all these great speakers and in doing this symposium. I think Robert already gave you all of the housekeeping things. I was about to say that we are going to be taking a break from 2:55 to 3:15, and there will be some refreshments served during that time. And also, we're going to have a panel discussion at the end. I don't know why I can't get this. There's going to be a panel discussion at the end where all of our speakers will come up on the podium. And one other thing I just wanted to mention before we get started is that this is a recorded session, so please try to speak into the mics. And when you're asking a question, go up to one of the mics, because otherwise we won't be able to hear you in the recorded session. So with that said, I'm just trying to figure out You would think I'd know how to do this because I had a little lesson before we started here, but I can't. I might need the AV help because I cannot get the mouse to come onto this screen. Can I have the AV person up here, please, for a second? Because I can't get the... Maybe you know, Robert. I don't know. I can't get the mouse onto here. See, it's not going over there. See what I mean?
Yeah, oops.
Oh, there.
Yes.
You just got it. Okay, wonderful. Thank you so much. So our first speaker is Dr. Jonathan Silverberg, who needs little introduction in this group as well. Dr. Silverberg is professor of dermatology at the George Washington University School of Medicine and Health Sciences in Washington, D.C. He's the director of clinical research and contact dermatitis. Dr. Silverberg's area of clinical subspecialty is inflammatory skin disease, particularly atopic and contact dermatitis. His publications include more than 1,000 peer-reviewed articles. How many people can say that? Abstracts and book chapters. He's also the chair of the annual Revolutionizing Atopic Dermatitis Global Conferences, and they're wonderful conferences if any of you have a chance to attend them. And without further ado, I will go ahead and introduce Dr. Silverberg.
Thank you very much for the kind introduction. Thanks for having me. So I'm going to try to take you all through most of like dermatology residency training in about 20 minutes or less, which might be a bit hard, but I want to cover some key points which, I mean, literally what I deal with all day and all night in my practice. So these are my disclosures. I'm not talking about any therapy. We're sticking all in clinic, but just I'm heavily involved in drug development. I will do everything I can to give a fair and balanced presentation. So let's start with a clinical presentation. I'm just at a high level. I think we all understand this already, but just to level set terminology, you know, in general, there's a lot of disparate use: eczema, atopic dermatitis, atopic eczema, and there's reasons globally why that has come out to be. But I'm going to use eczema as more of a morphologic descriptor, whether it's a visual pattern or whether what we see histologically, whereas atopic dermatitis would be an etiology, a specific disorder of the eczematous family. And, you know, residents ask me all the time, well, what is an eczematous morphology? What is the hallmark lesion of atopic dermatitis? And it's actually really hard to define morphologically. The best we can really give would be these sort of ill-demarcated, ill-defined patches or plaques, which is really in contrast, and you see that here on the popliteal fossae. You can appreciate something's off. There's accentuation of the skin lines. You can appreciate some erythema. But it's kind of hard to figure out where the boundaries of that start and stop. You know, histologically, here we see on top, this is acute eczema, which is more of what we see that little space in between the so-called pattern of spongiosis, which is really an artifact of when processing the tissue. Whereas with chronic eczema, you'll see more of this, almost what looks like psoriasis, thickening of the epidermis, and as well as hyperkeratosis, scale, etc., and more dermal infiltrates. Now, how does this contrast to plaque psoriasis? And here we see what would be a really textbook case of plaque psoriasis, where you could almost draw a pencil mark around it perfectly, right? It's super well demarcated. And that's, you know, even within psoriasis, there's a lot of variability in the morphology, but that's sort of a classic distinction we'll make. When thinking about the eczematous morphology, though, it's not specific to atopic dermatitis, whether it's clinically speaking or whether it's under H&E, you know, in terms of biopsy. We'll see the same exact histologic pattern or sometimes clinical pattern show up in patients with atopic dermatitis, to some extent in those with nummular dermatitis, drug-induced dermatitis, allergic contact dermatitis, and irritant contact dermatitis. But of course, the trigger scenarios are totally different, and how we would manage that would be entirely different between these different disorders. When we think about the clinical presentation of atopic dermatitis, now we have to start thinking about sort of the clinical constellation and patterns of how that eczematous morphology distributes or appears. So we're classically taught to think about, you know, in infancy, there's this facial and scalp dermatitis that comes up, often sparing the diaper area. Now, this is not always true. You certainly have facial dermatitis that is not atopic dermatitis, and you have plenty of patients who will go straight to flexural disease without any facial dermatitis. But very commonly in that infantile period, there's a very characteristic, it's just incredibly inflamed, intensely, erythematous, often oozy, crusty, weeping, acute eczema lesions. Whereas in the adults who have facial dermatitis, it tends to be much more of that chronic, dry, scaly eczema. With toddlers, we'll tend to see more of extensor dermatitis, although again, this is not unique to toddlers by any stretch, but it often is thought because they're crawling and getting into things, perhaps more from friction, more about dust mite, potentially as an irritant exposure. And then we see more of the classical flexural distribution, or what we are taught to be classical distribution. And I want to challenge this a little bit. So if you see a patient with flexural dermatitis presenting this way, you have the ill demarcated lesions, you could appreciate it's itchy because there's a lot of evidence of scratching, there's lichenification. Generally speaking, if you guessed atopic dermatitis, 9 out of 10 times you would be correct. Although the literature is replete with many case report and case series of flexural dermatitis that were actually allergic contact dermatitis mimicking atopic dermatitis, tends to be more so in the adult realm than in the kids. The other issue I want to draw your attention to is from a diversity perspective, is that flexural eczema is much more common in patients of Northern European descent. You actually see much lower rates of flexural eczema in patients of African descent or Asian descent. So if the only thing you're looking for is flexural lesions, you're actually going to have bias in the way you're looking at patients of diverse populations. Now, something that I think we're not often taught enough about is, and this is a big part of the bane of my own existence, because I see all age groups, but a lot of adults, is the adult pattern of atopic dermatitis. And this tends to involve much more of the head and neck, and much more of the, I'll show you on the next slide, hands and feet. And what's tricky about this is it can be a transformation in the disease where they have maybe full body as a kid, but not so much head and neck involvement. And then as an adult, they start to get more of that. And then you're left figuring out, well, is this just an evolving pattern of atopic dermatitis, or is this allergic contact dermatitis that has now developed over time? And we see that come up a lot. So patch testing can certainly be helpful in these scenarios. But these are all patients with atopic dermatitis affecting the head and neck who didn't have overlapping contact dermatitis. Now, for the hands and feet, this is a particularly impactful set of sites anyway because of their functional significance, occupationally, just activities of daily living, even being able to walk. And this is something that is much, much more common epidemiologically. You don't even see hand eczema in any real demonstrable prevalence until adolescence. And in general, the prevalence just skyrockets into adulthood. But we see this in particularly true in the atopic dermatitis patients as well. And this is a very challenging site. But we need to think about this from an etiology standpoint. When we see patients who have a dominant hand eczema pattern, who have maybe a history of atopic dermatitis, what are we looking at? Should we just assume it's atopic dermatitis, or should we dig deeper and think about irritant or allergic contact dermatitis? I also wanted to address some of the different morphologic variants I alluded to earlier in skin of color. So here we have an example of a patient with, hopefully that you can see the mouse, but we have a patient on the left that this is just classic atopic dermatitis in a patient with a darker phototype. Now you'll notice it doesn't look quite as that light pink red, more purplish. What in dermatology we often describe as violaceous, and you start thinking about lupus or connective tissue disorders. But in fact, this is just atopic dermatitis in darker skin tones. This patient was biopsied twice, completely unnecessarily. They had a lifelong history of atopic derm, and that's all it was. In the middle, we have an example of a scenario with what we might think of as pigment masking, where sometimes you're not exactly sure what is active or what's not, because you'll have this post-inflammatory hyperpigmentation that comes up, or an inflammatory hyperpigmentation that comes up, and you don't necessarily appreciate the erythema quite as well as you might in patients with lighter skin. On the right, we have an example of follicular eczema. I don't know how well it projects on the slide, but these patients are often thought to just have dry skin, when in fact, it's not just dry skin. It's not just keratosis pilaris. This is a distinct morphology of active inflammatory lesions that will be highly responsive to a variety of different anti-inflammatory lesions. That's not the case when you're thinking about just dry skin. On the left here, we have dorsal lichenoid papules. So this is an important one because To me, it's a fascinating pattern. We see this almost exclusively in patients of African descent, depending on the regions of the world where the studies were done. And the patients are chronically rubbing their skin. In this case, you'll notice there's an accentuation of the skin lines or lichenification, but there's also these discrete little whitish, almost pearly papules on the dorsal hands, where for whatever reason, the host response is different to chronic rubbing, where we get this morphology. I've had many of these patients biopsied unnecessarily to rule out lichenitis or lichenoid disorders, but in fact, this is just classically what we'll see atopic dermatitis-wise in skin of color. And this is a patient where they were actually thought to have psoriasis by another dermatologist, but in fact, it was just atopic dermatitis and skin of color. It's tricky, right? Because it's extensor, and it's a little bit more well demarcated, so I could see why you would think that. But in fact, this is really just atopic dermatitis, and you had to look at the whole patient to appreciate all the other stigmata supporting atopic dermatitis. So how do we diagnose this? It's a clinical diagnosis. The original criteria, and arguably still the gold standard, would be the Hanifin and Reicha criteria, developed back in 1979 by John Hanifin, who was, when I was a resident, was referred to by my program director, Vince DeLeo, as the Pope of atopic dermatitis. And so there are a few people who I think have that degree of insight into the disease. But even so many years later, these have really stood the test of time and are still the most commonly used criteria in clinical trials. Now, the tricky part about this is you have to meet 3 out of 4 major criteria or 3 out of 23 minor criteria. So you can imagine no one in clinical practice actually wants to use these, and understandably so. So we've got all these revisions to shorten them, make it a bridge. You have the UK Working Party criteria, and Japan has their own way of doing it, and China recently came out with their own guidelines for this. Use something, but you have to, I think, recognize that, you know, on the one extreme, not everything red and itchy and eczematous is atopic dermatitis. But on the other hand, don't fall into the trap of just saying the only atopic dermatitis I'm going to diagnose are the ones who have infant onset flexural disease. Because if you look at the criteria, what you see is that early age of onset is not even a major criteria here. It's a minor criteria. You can have later onset of the disease. Tough differential diagnosis to work through, and I'll show you that on the next slides. But you can really see that quite a bit. My practice is just full of it. And then the other thing is flexural eczema is one major criteria. But you could meet criteria for atopic dermatitis without it. So keep those few pearls in mind. And then for the allergy group, of course, elevated serum IgE is a minor criteria. So I still hear of allergists who routinely will check IgE testing to support the diagnosis. You don't need to. I mean, you may have reasons you want to figure out if you should do additional allergy testing or worry about, you know, different triggers. But from a diagnostic perspective, completely unnecessary. All right. So how do we make these, you know, what other tools can we use? I find that this is a very complicated dialogue and narrative between allergy immunology versus dermatology, because, you know, sometimes, you know, you're not sure what you're looking at. You send to your dermatology colleagues to biopsy, and sometimes they get sent back to you with less information or a biopsy that's even less helpful than what you thought in the first place. Biopsies are not magic in these scenarios. Most of the time, they're actually going to be useless. And that's a strong term, and I know I'm being recorded saying that, but most of the time they're going to send you down the wrong direction. I can't tell you how many patients have been referred to me for patch testing when they had psoriasis, but because some biopsy called it spongiotic dermatitis with eosinophils. The other thing is sometimes pathologists write very declarative statements where they'll say, this is atopic dermatitis. There's no way they can know that from pathology. All they can know is eczematous. Now you have to do the work of clinically figuring out what is the etiology of that eczematous eruption. Now, it is sometimes helpful to rule out things like cutaneous T-cell lymphoma, for sure, and that's a complicated one, and unfortunately, you may have to biopsy 4 or 5 times so you actually figure out if they have, you know, or can get the path to demonstrate clearly cutaneous T-cell lymphoma, but it can be helpful certainly to rule out other morphologies as well. There's no valid biomarkers right now that we use or that have any, you know, great fidelity. No blood tests that are really well accepted. And then, you know, we don't recommend food allergy testing routinely to support the diagnosis or even in general once you know they have atopic dermatitis, except for those few scenarios of extremely refractory cases or history of specific worsening with foods as shown in the allergy guidelines. So what about patch testing? Now here, I think there is value. Now, my own bias, I'm part of the North American Contact Dermatitis Group. I'm a patch tester. This is what I do all day and all night. But I got to tell you, we come up with positives all the time that are truly relevant. But there are some things to know. So what are the subsets? We don't have evidence-based guidelines. We do have consensus guidelines from a multidisciplinary group. Amongst the allergists on this panel was Mark Boguniewicz and others. But Adolescent or adult onset, you should think about the possibility of contact dermatitis. Lesional distribution, that's atypical. Maybe, hands, for example, or eyelids. Now, that's true in general if you have a localized dermatitis, but certainly true in the atopic patients as well. If their dermatitis is just so refractory, it's not responding to therapy the way you would expect, you have to think about, is there some additional allergenic trigger that just keeps making it worse? Prior initiation to systemic atopic dermatitis therapy is basically like a Hail Mary scenario. Before you put them on lifelong systemic therapy, you might want to just make sure there's nothing easily avoidable. And then if the atopic dermatitis worsens or rebounds with therapy, think about the possibility of an allergy to topical steroids. I've had many patients who came into me swearing they had steroid withdrawal or steroid rebound, steroid phobia. There's a lot of different terms that are used on social media, when in fact they had allergies to class BD topical steroids, or had allergies to propylene glycol or other excipients used. And so yeah, they did have a withdrawal phenomenon, but that's what we know happens when you have an allergy to your topical medications. The medicine will work early on, but as the medication effect wears off, then the allergy kicks in and sets off and gets things worse. All right, so let's jump into what else you might see and what you need to think about. So this was a patient who was sent to me. These are like fun cases, but it's really just to get you thinking, because you're not going to master all morphology instantly, but just some scenarios to think about in the last few minutes. So this was a patient who was astutely sent to me for patch testing by an outstanding dermatologist when I was still practicing at Northwestern. And this is what showed up after lots of aggressive topical therapy. And you probably look at this and you're like, I don't see a whole lot. I'll draw your attention to the lower left back area where there's sort of this ill-demarcated, very subtle light pink, lesions. There's more of it on the right side as your eyes start to train on the erythema. It is an eczematous morphology, very nonspecific. It was covering head to toe. This patient was on numerous rounds of systemic therapies and steroids. And we worked on trying to get him optimized for patch testing, thinking about, could this be a contact dermatitis? Certainly could be. We optimized him topically. He comes back, he's pretty much clear on the back, but then he shows up with this. And it's like, oh my gosh, what is this? So now I start thinking, is this autoimmune blistering disease? Is this bullous pemphigoid? What is going on? We biopsied, we did an H&E, and for these you'd have to do a DIF to also look for if there's autoimmune blistering disease. And it came back spongiotic dermatitis with eosinophils. Well, this time it was actually correct. And the DIF was negative. This was a systemic contact dermatitis to nickel in green tea. This is a once in career, because so many patients you find with nickel positives and they're meaningless, or they're relevant to the earlobes, but not systemically. Most of the time you could put them on all the nickel avoidance diets, not going to do anything. This was a patient, he said he bought an imported black tea from India on Devon Avenue. If any of you know Chicago, Devon Avenue is like the cultural epicenter of the Midwest. And he said it had a metallic taste, but he liked it. And it turns out he just stopped the tea and literally everything completely melted away after 6 or 7 years of in and out in the system, hundreds of thousands of dollars of healthcare utilization. Now, psoriasis. This was a patient who was sent to me for enrollment in the tralokinumab clinical trials by an expert dermatologist in the Chicago area. Okay, and I saw this patient. I always check my patients before, and I trust no one beforehand. And I said, I can't put you in the trial. He said, why not? I said, because you have psoriasis. He says, no, I don't. And we were doing this like Laurel and Hardy bit. No, I don't. Yes, you do. No, I don't. He said, it can't be. I've been told I have eczema for the past 10 years. I said, I don't know what you had 10 years ago, but I know what I'm looking at right now. This is psoriasis. I said, I don't need to biopsy this, but if you want, I will just to prove it. Came back psoriasis. He ended up doing great on targeted therapies for psoriasis. Now, I don't know where the disconnect came in the initial diagnosis, but what you should look for here is these are more well-demarcated lesions, not perfectly well-demarcated, but more well-demarcated. You'll see generally more scale. In lighter skin types, the erythema tends to be much more prominent and rich and more noticeable than what you might see in an eczematous pattern. But in this patient, I think probably what threw the previous dermatologist off is here we see lichenification, accentuation of the skin lines in the lesions. But that can happen in psoriasis too. It's not unique to atopic dermatitis, because if they're super itchy and they rub, they'll get lichenification. So just keep that in mind. Look at the whole picture, not just at something like lichenification. This was a patient who was enrolled by another center before they ever came to see me in a trial for a JAK inhibitor for atopic dermatitis. and didn't get better, was considered a non-responder. Just shows you how to interpret clinical trials can be very complicated. The reason why she was a non-responder was because she had cutaneous T-cell lymphoma all along. It was never atopic dermatitis. Adult onset case, the morphology never looked typical, and so we biopsied, and eventually, it took a couple of biopsies, but eventually came back as mycosis fungoides, cutaneous T-cell lymphoma. This is the dreaded one you don't want to miss. In kids, usually you're not going to have to worry about this too much, but for any adult onset case, you should be thinking about this. And maybe don't withhold therapy till you have that answer, but at least keep that in the back of your mind at all times, make sure you're not missing it. It's generally a little bit more well demarcated, although it can look identical to garden variety atopic dermatitis. This is a tough one to know, but here you see a little bit more of an arcuate shape or more annular shapes that come up. That's going to be something that's a red flag for classic atopic dermatitis. This was a patient who was referred for atopic dermatitis, and if you look at the right, there's flexural lesions there. Right? Flexural dermatitis happens to be the patient had lifelong atopic dermatitis since I was a little child. But all of this is not atopic derm. This is lupus. And this was a patient, the erythema was off. It was a little bit more of a violaceous color, although in a phototype 3-4, sometimes the atopic dermatitis will look like that, but this kind of discrete, more papular morphology is not consistent with generally with atopic dermatitis. The involvement of terms of the head and neck, there was a lot of rich dyspigmentation that was left behind, and the patient had some mild flexural lesions, but this was cutaneous lupus, and it was just an odd overlap. Although there are lots of case reports out there of atopic dermatitis, eczema-like lesions showing up in lupus patients. The scabes. So you got to be thinking about this. For your chronic patients, it's going to be less of an issue, but if you're seeing acute onset dermatitis, you need to think about this possibility of scabies because this is easily treatable. This is should not be a chronic disease. Ask about the history, family history, or exposures that may have additional itchy rashes as well. And generally speaking, you're not going to have a lot of head and neck involvement. It's going to be much more about, the rest of the body. And you can look for little, what we call burrows, where there's little mites like to get in these moist areas. And the last entity I'll talk about is drug-induced eczema, something that I think is on almost nobody's radar because there's very few publications about it. There's 2 well-done publications, one first done in JAMA Dermatology, and then another, or actually, the first one I think was in Journal of Investigative Dermatology, and the next one was in JAMA Dermatology. And what they found is it's non-flexual, generally speaking. It's usually going to be the elderly patients, elderly onset. It can look very much like atopic dermatitis, sans the flexual lesions. And what has been implicated the most have been calcium channel blockers, and to a variable extent in the second study, potentially thiazide diuretics as well as beta blockers as well. Now, it's something that, just to put proper context, because I've suspected this in probably now somewhere in, 80 to 100 patients, and I never make these switches on my own, but I'll work together with primary care to switch the class of, especially if they're on a calcium channel blocker to begin with, and I would say I got a grand slam home run in about maybe 8 or 9. Right, so it's only about 10%, maybe less, where you're going to get that success of switching therapies because there's plenty of other reasons why patients get adult onset dermatitis. But for those 7, 8 patients, however many it was, they were about to go on long-term systemic biologic therapy that they would have never gotten off of it, ever. And I'm not sure it would even have worked well in those scenarios. And here, all we had to do was switch around their medication, and they literally just cleared over several months. So keep this in mind. It's not the most common scenario, but it is something you don't want to miss. And with that, I thank you for your attention.
Thank you very much, Dr. Silverberg. We're going to move on to Dr. Emma Gutman-Yassi. This is a recorded talk. Dr. Emma Gutman-Yassi is the System Chair of the Department of Dermatology and the Waldman Professor of Dermatology and Immunology at the Icahn School of Medicine at Mount Sinai. Her major research focus areas are atopic dermatitis and alopecia areata, and she is a co-founder of the IEC and immediate past president. And this is like I said, a recorded talk.
Hi, everyone.
The volume, though, is an issue.
Yes.
But I think we control the volume as well. Yeah.
I was told that we had maybe a person,
I'm
but I
really
don't know where they
excited
went.
to be invited to give this talk
That's the
on
loudest.
development of a precision medicine approach in atopic dermatitis.
It's better than before,
and
at least.
I really wish I was there
What did you
in
do?
person, but I'm really
Split
happy
screen.
to be
It
with you
extends
today.
onto the next
I'm
one, so
coming
drag
from
it
New
over.
York City, where I'm the chair of the Department of Dermatology at the Icahn School of Medicine at Mount Sinai, and I'm also the past president of the International Eczema Council. So atopic dermatitis is very familiar to all of you, and we need to remember this is the most common inflammatory skin disease, and maybe the most common inflammatory disease we have in humans. In the United States, it's 7% of the adults, but there are countries where we have a little bit more or a little bit less. In Europe, 3 to 4%, in Asia, about 10%, 15 to 25% of the children worldwide, and about a third of the patients will have moderate to severe atopic dermatitis. And until very recently, we had a large unmet need for long-term disease control. Yes, we did have treatments for patients, but not a treatment that we could give patients safely for long-term disease control. And I hope to show you today that the therapeutic drought is finally ending in atopic dermatitis. Now, as Donald Liu and I highlighted in a review, and many others also highlighted, atopic dermatitis is characterized by both immune and barrier abnormalities. And that's the reason why drug companies for many years did not know what they should go after. Should they go after the immune abnormalities? Should they go after the barrier abnormalities? And that really prevented therapeutic development in atopic dermatitis. So when we talk about the immune abnormalities or inside out, we are primarily talking about Th2 and Th22 abnormalities with increases in cytokines such as IL-4, IL-13, IL-31 and IL-22, but also interferon gamma in later stage and other cytokines as well. And there is a very vast barrier abnormality in atopic dermatitis with abnormalities in terminal differentiation molecules such as filaggrin, loricrin, also tight junctions and lipids, allowing penetration of allergens, microbes, and also irritants. And all of this is creating the atopic dermatitis phenotype that we know. And of course, there is a very big component of each as well in patients with atopic dermatitis. Now, let's review how did we get to the successful point we are now in today in atopic dermatitis that maybe is emerging as the disease that is really a good example of translational medicine approaches. So we got through bench studies of pathogenesis that included biomarkers in both skin and blood that helped formulate pathogenic hypotheses. But these hypotheses needed to be proven, and they were proven by clinical trials with targeted agents that also included biomarkers or therapeutic response biomarkers, and multiple cycles resulted with therapeutic generations. And like I like to tell my fellows and mentees, not only successes, but also failures, like everything else in life, are important because they are helping to frame pathogenic concepts and the therapeutic directions we are going. So I want to show you today how did we get to this point in atopic dermatitis and how are we doing the next stage. So to develop a translational medicine approach in atopic dermatitis is not as easy as one may think, because unlike psoriasis, atopic dermatitis is more difficult to quantify clinically, leading to very high placebo responses. So thus, I think to define a specific biomarkers in atopic dermatitis in both skin and blood is really important, because we need to measure the disease in a more objective fashion, right? The lesional skin is merging with the non-lesional skin, and it's really hard to quantify where one ends, one begins. We want to identify pathogenic pathways, and we want to develop precision medicine approaches. Currently, skin profiling is considered the gold standard for investigative biomarkers of disease. Blood profiling provides more limited information, but is still useful for patient stratification. And it is really important also to develop minimal invasive skin biomarkers such as tape strips in both adults, but particularly also in children, where it's so hard to obtain skin biopsies. and defining biomarkers in specific phenotypes of AD based on age, ethnicity, and others can assist in therapeutic selection and trial design. So in 2012, we put together this paradigm shift in the pathogenesis of AD, suggesting that it doesn't matter what starts first, the barrier abnormalities or immune abnormalities, because the immune abnormalities are perpetuating the disease phenotype into chronic stage. And I think that is quite accepted now in the literature, and you'll recognize many of these molecules as being targeted now in clinical trials. And also we need to remember that important Th2 and Th22 cytokines have important actions on the barrier. For example, IL-4 and IL-13 inhibit antimicrobial peptides. We all know the relationship of patients with atopic dermatitis and Staph aureus. They also disrupt barrier molecules, decreasing filaggrin, loricrin, involucrin, and lipids. IL-31, the itch cytokine, is starting this itch scratch lichenification cycle, and IL-22, that is derived from Th22 cells, starts the onset of hyperplasia, and together with IL-17 synergizes to induce the S100s. And then we have interferon gamma that comes into play in chronic stage. So now we need to ask the question, is atopic dermatitis a single disease across the spectrum? And the answer is no. Unlike psoriasis that is much more homogeneous, focusing on Th17, IL-23 biology, here we have multiple clinical phenotypes that have also differences in immune polarization and barrier defects. Just to give some examples, children with atopic dermatitis, they do not have Th1 polarization, they have higher Th17 polarization. African Americans, again, do not have Th1 polarization. Asians with AD have increased Th17 polarization. And these also relate to barrier defect differences between the phenotypes. Importantly, all the atopic dermatitis subtypes are sharing a robust type 2 immune activation. However, we do need to stratify based on biomarkers that are specific to different phenotypes in order to get us to a personalized medicine approach in atopic dermatitis. Now, recent studies that we've been doing, we try to compare between infants, children, adolescents, and adults with atopic dermatitis. And when I say compare, we wanted to define what is the core phenotype of patients with AD versus differences in phenotypes. And what did we discover? That the core phenotype in skin biopsies, and this is a collaboration with Amy Paller, and Amy managed to get skin biopsies from infants, children, and adolescents and adults, and we collaborated on the analysis. So in all of them, there are Th2 and Th22 molecules that are increased, and there is a core phenotype that all of them have increases in these molecules such as CCL17, CCL22, CCL18, IL-13, IL-4 receptor, and the Th22 related molecules IL-22 and S100. So these are common to all of them. So these I feel we can call AD bona fide biomarkers because they are common to all the phenotypes. However, there are phenotypes that have only some molecules but not others. For example, at atopy initiation in infants, we have increases in IL-5 and IL-33. And remember, targeting IL-5 and targeting IL-33 did not work in adults, no wonder. But one may think maybe these will still be relevant in children. And Th17 related biomarkers such as IL-17 and IL-17A and F are increased in infants. And in adults, we have Th1 related markers such as CXCL9, CXCL10, CXCL11, and MX1 that are increased. And these have been associated with chronicity of the disease. Interferon gamma and chronic disease and Th1 are increased in adults. So these differences are important because maybe we need different targeting in different phenotypes based on age, as I show you here. And we also showed that epidermal barrier abnormalities differ in different age groups. While they are seen in all patients, terminal differentiation abnormalities such as in filaggrin, loricrin, are higher in older age groups. but infants present the greatest downregulation in lipid barrier genes. So terminal differentiation abnormalities increase with life, but lipid abnormalities actually are highest in infants. And another important concept that I think is also very relevant to therapeutics is the idea that inflammation is more than skin deep. Atopic dermatitis emerges based on many studies as a systemic disease with markers linked to atherosclerotic signaling increased in both blood but also in skin. And we've showed in several studies that the skin is likely the source to these increases that we see in blood in atherosclerosis linked markers. And also this was shown by several population-based studies showing that atopic dermatitis is associated with cardiovascular disease. And in some studies that we've done in blood from atopic dermatitis patients throughout the ages, from infancy to children to adolescents to adults, we show that in all of them, they have in the circulation type 2 inflammation, but of course there are some immune axes that are different. For example, IL-22 producing cells are much more increased in adults, whereas in children, the only game in town is a type 2 inflammation. And also we see increases in IL-9 in children, and IL-9 is a link to allergy as well. Now, another important concept is the idea of the vascular inflammation that I already talked to you about. So we now see that patients with atopic dermatitis as compared to controls, and this is very elegant work from Benjamin Unger from Mount Sinai that I'm very proud of now setting his own lab. So he showed that patients with atopic dermatitis using PET-MR have inflammation in the aorta and carotid, again giving more confidence to idea of the systemic inflammation. So not only systemic inflammation, but also vascular inflammation that is increased in atopic dermatitis patients compared to controls. And this is also, of course, reflected in the fact that patients with atopic dermatitis, they have even abnormalities in their non-lesional skin. So not only the lesional skin, but you see here clear-cut increases in Th2 and Th22 associated molecules in both the lesional skin, but also the non-lesional skin. So to put it all together, to get to the right AD phenotype, we need to capture both abnormalities in skin, but also in blood biomarker to really understand the phenotype of the patients. And when we look at the skin, we need to also think of lesional skin and non-lesional skin. And now let's move on and ask the question, how are we testing the contribution of the different cytokines and the different immune axes to atopic dermatitis? We are doing it through clinical trials with targeted treatments in AD patients that, of course, it's best when they are coupled with biomarkers. So let's see. And the first one, of course, is dupilumab that targets both IL-4 and IL-13 because it targets the receptor, and IL-4 and IL-13 are important to the barrier dysregulation in atopic dermatitis. And in this study, this is the biomarker study, the phase 2 biomarker study with dupilumab, in which we had 54 patients, 27 started on drug, 27 started with placebo. Patients were treated for 16 weeks. And you can see here clearly that in placebo, you don't have movement in biomarkers. In dupilumab, very clearly you see that major downregulation, so red is turning into blue. Multiple markers are decreased, primarily type 2 markers such as CCL17, CCL26, CCL18, but we see markers beyond that, IL-17A, CXCL1, S100s that are part of Th17 and Th22. Importantly, there were no changes in type 1 inflammation. So interferon gamma and CXCL9 did not change. And the barrier-related molecules also changed. And this is shown even better here when we study the barrier defects. And you see at baseline that hyperplasia characteristic to atopic dermatitis. It's completely normalized at week 16. Lesional looks very similar to non-lesional skin. Keratin 16 staining is completely turned off only with dupilumab, and the epidermal thickness is reduced by 40% at week 16. already at week 4, you see significant decrease in epidermal thickness. Now you'll ask the million-dollar question, what happens with filaggrin? Look at the skipped expression at baseline that is characteristic in atopic dermatitis. It is normalized at week 16 with dupilumab. So dupilumab impacts not only the inflammation of AD, but also the barrier dysfunction that this disease has, establishing for the first time the Th2 axis and IL-4 and IL-13 cytokines as pathogenic in AD, cementing it as a reversible immune-driven disease like psoriasis, and really opening the door to all the therapeutic development that is ongoing. Now, dupilumab also inhibits systemic Th2 inflammation, and is shown here by reduction in CCL17 and CCL18, two key Th2 biomarkers. Pay attention, they are reduced with dupilumab, not reduced in the placebo arm. Now, we've also done a study with IL-22 targeting that was funded by the NIH with fezacizumab, a drug that was on the shelf of Pfizer. And we did that as a proof of concept to show if targeting IL-22 is a potential for atopic dermatitis and also is part of the pathogenesis. IL-22 is important to the barrier dysfunction of AD and to the hyperplasia. And I think you'll see that the answer is yes. This was a monotherapy study. Today we would have done the study differently. We placed the primary endpoint at week 12. We had 60 patients, 2-to-1 to placebo, a very small study for AD. But luckily, there was a secondary endpoint at week 20 as well. So what you can see, we did not achieve significance comparing drug to placebo at week 12, but we did achieve significance at week 8. And when we did a regression model, we found at multiple week significance between a drug to placebo. So then we divided the patients to severe patients with scored more than 50 and moderate patients. These are the non-severe, scored in more than 25. Pay attention that in the severe patients, you find significance at multiple weeks, but that's not happening in the non-severe patients. And we asked ourselves why, and we did a mechanistic study in which patients had biopsies, and this is a gene array study from that a biopsy study. Red is upregulation, blue is downregulation, and here we divided the patients based on median IL-22 expression to higher than median or lower than median. And what do we see here? In the patients with high baseline IL-22, there is a large improvement. Red is turning into blue, blue is turning into red. So at week 12, you see that the lesional skin looks like non-lesional. That's not happening in the placebo arm. However, in the low baseline IL-22, there is not an improvement, and even we see worsening, right? Blue is turning into red. So unfortunately, we made the patients worse. We didn't want that. But this I find to be the first example of personalized medicine in atopic dermatitis, and I believe in dermatology in general. And we feel that more of these studies should happen because I think eventually we'll go to that personalized medicine approach in atopic dermatitis. And this is a patient with very lichenified lesions before and after, and she stayed clear for several months. And as you know, there is now an IL-22 receptor going into the clinic. So very exciting time, I think, for me to see that maybe we will have a treatment targeting IL-22, not in the so far future. Now, another exciting new target is OX40. And OX40 is primarily expressed on activated T cells and binds OX40 ligand on antigen-presenting cells. And this drug from Amgen and Kiowa is a fully human monoclonal antibody that inhibits OX40, and it inhibits activated T cells, including Th2 T cells, inhibiting memory T cell formation. And this study had an interesting design with treatment period A until the primary endpoint and treatment period B until the secondary endpoint. The first period was placebo-controlled, multiple doses. Pay attention that all of them achieved significance compared to placebo. But then they wanted to evaluate, because it's a slow-acting drug, how all the doses achieved efficacy, and the placebo patients were put on the highest dose. And pay attention that it still continues to improve. So week 16 or 18 are not the best. You keep giving drug, and week 36 still is creeping up. But the most important thing here is the durability of response. What they did at week 36, they stopped drug and they evaluated for another 20 weeks. And here you see that the patients on the higher doses, they maintained, majority of them, more than 90% maintained EASI 75 until week 56. This is quite unique. And this was also substantiated by biomarkers in blood and skin. Pay attention here, TARC, CCL17 stays low until week 56. Remember, the drug was stopped at week 36. IgE not only stays low, but goes even more down. And total OX40 helper T cells in peripheral blood again stay very low. And IL-22 producing cells also stay low almost the entire time. And OX40 positive cells in the upper dermis, I'm not showing you here, but they were eliminated in the skin, in the dermis, from week 8 through the withdrawal period. So it was maintained throughout. And that's very important, that the biomarkers are also providing support to that potential for disease modification with this drug. Now, this is a heat map of gene arrays that we've done, and you see here placebo and drug at multiple weeks, week 0, 8, 16, 36, 52, and non-lesional week 0 and 16. And pay attention to the fact that nothing is going on in the placebo arm until week 16. You do see changes later, but later, remember, they were put on drug. And also in placebo, you see actually an exacerbation in the non-lesional skin between week 0 and week 16, whereas with drug, you see gradual changes until week 52, and the non-lesional also improves between week 0 and week 16. And we did a transcriptome deconvolution analysis to take the transcriptome and look by different cells. And here you see multiple key immune cells that change with treatment, including Th2, Th17, dendritic cells, effector memory CD4 and CD8, neutrophils, and keratinocytes that were modulated with treatments. Again, red is increases, blue decreases. So of course you see increases at baseline and decreases later on. Now I want to take a little bit of time and talk about the development of less invasive biomarkers in atopic dermatitis. I'm very passionate about that, particularly that a large portion of our patient population are children. And here I want to talk about tape strips, and that was introduced as a detection method of melanoma, so as to identify pagetoid melanocytes that are present only in melanomas by superficial tape strips. It removes stratum corneum and upper granular layer. The benefits are non-invasive, scarless, and painless, and we and others adapted it to study inflammatory skin diseases. So one of the first studies that we've done wanted to look at the phenotype of atopic dermatitis and psoriasis in tape strips and compare it to normal skin to see if we get the same data that we get in skin biopsy. So first of all, we got multiple differentially expressed genes, definitely in line with what we get in biopsies, more than 4,000 in one disease and more than 5,000 in another disease, using the same criteria of fold changes more than 2 and false discovery rate less than 0.05. And we also obtained a single classifier, NOS2, as being able to 100% classify these two diseases. Next, we did a study looking at children, infants and adolescents with controls of each one of them, controls, non-lesional and lesional, to look at the phenotype in children and how it changes over time. So we saw that all of these age groups, infant, children, and adolescents, have increases in Th2 and Th22 genes such as CCL17, CCL18, and S100s. These are already increased very early in infants, but barrier genes such as loricrin, filaggrin, and claudins show a greater dysregulation later in childhood. So not very early on in infants, but later in childhood. And RNA-seq profiling in biopsies and in tape strips was extremely highly correlated, as you can see in our paper. Now, this is a word cloud representation where the fold changes are represented. So the higher the words that you see means that the higher the fold changes. And when you look, you see that the phenotypes by age of infants, children, and adolescents, and this is non-lesional skin compared to healthy, they are similar, but there are some differences. For example, you see very early on in life, again, a huge lipid down regulation. You see some of the lipids very large words, but overall the phenotype is similar with some differences based on age group. But pay attention, the CCL17 showing there, as you know, CCL17 was shown to predict occurrence of atopic dermatitis later in the infancy, and it's definitely one of the major biomarkers seen in infants. And you see also a downregulation of loricrin and filaggrin, and then later on you see increases also in some TH17 molecules, such as CXCL1, that increase in adolescence, and claudins are becoming much more decreased in adolescence, and the same with filaggrin. Now, can tape strips be used to evaluate biomarkers of therapeutic response in atopic dermatitis? And the answer is yes. And here we looked at biomarkers in before and after dupilumab using gene expression. And you see in the Th2 biomarkers, CCL18 and CCL13 decreased highly significantly after treatment, and terminal differentiation markers such as filaggrin increasing with treatment. And we also compared the tape strip and the biopsy data, even though it's not the same patients, but just to see that they are in line. And here I show them side by side. You definitely see that they are definitely in line. Lesional and non-lesional skin are decreasing in tape strips, both CCL18, CCL13, CCL17, and CCL26. I'm showing here only Th2 biomarkers, but that was irrelevant to other biomarkers as well. And a biomarker is not a biomarker if it doesn't correlate with the improvement in disease severity, and this is what we see here. First of all, in our patients, the easy improvement was 70%, similar to the clinical trials. And you see, for example, here, CCL13, a Th2 biomarker, correlated significantly with easy. And many other biomarkers correlate with the severity improvement and also with transepidermal water loss as well. Now, we also performed proteomics before and after treatment, and that also yielded a very nice data. Again, here you see CCL17 and CCL13 decrease with dupilumab treatment after 16 weeks of treatment. Now, we need to ask the question, can the translational revolution in atopic dermatitis also extend to alopecia areata, a disease that becomes recently as being part of the atopic march? In alopecia areata, the highest comorbidity is atopy, particularly eczema, but recently we know that asthma, allergic rhinitis, and any atopic comorbidity increases the risk to develop alopecia areata. And GWAS studies actually associated IL-13 as the highest association. So the answer is yes. We did recently a study with dupilumab in adult patients with alopecia areata, and we hope to do also a pediatric study. We submitted for NIH funding because we feel that's a huge unmet need there. But in our adult study, we showed in a large group of patients that having high IgE at baseline and or a background of atopy could predict dupilumab responses. So patients that had an atopic comorbidity or high IgE responded better, as you can see here by the correlation. And in this graph, pay attention, high responses in the atopic group, more than the group of patients that don't have atopy. They responded somewhat, but definitely much, much less and much slower. And this is a patient with atopy that had alopecia universalis for 3 years, and he gained all of his hair, and he still has his hair to this date. And we also published recently the biomarker study that was done during the trial. And I'll walk you through the data here. I'm presenting the data here of patients that have a high IgE and or a history of atopy. And you can see here that the lesional scalp is basically blue is turning into red and red is turning into blue. So it becomes more of a non-lesional phenotype, whereas in placebo, you don't see that. Blue stays blue, red is staying red. Now, when we quantify the improvement in the lesional transcriptome towards non-lesional, in the patients on drug, we have 97% improvement. And again, these are the patients that have atopy or high IgE. So almost 100% at 48 weeks. And I think we hinted that the Th2 axis is pathogenic here because at 24 weeks, we have decreased Th2 axis. We do not yet have any change in Th1, but yet, pay attention, we already have increased hair keratins. So what does it tell us? I think this strongly suggests that the Th2 axis may be pathogenic early in alopecia areata, and maybe the Th1 axis is coming later to play, being important for the chronicity or for the maintenance of disease. So I think we are having a very exciting times. And in general, I think it takes a village to do meaningful science that benefits our patients. This is our department. So
I apologize to Emma's team, but I'm just trying to get us back on schedule here. We're moving
Thank you
on.
for joining me for this session at the Quad AI. I'm Alan Irvine from Trinity College Dublin, speaking as part of the IEC Symposium. And the title of this talk is The Leaky Barrier. I'm going to review abnormalities in keratinocyte differentiation, tight junctions, and lipids. And then I'm going to show a little bit about how we may have some barrier correction strategies and prevention. Just to look at the barrier, the physiology of and the structure of the epidermal barrier. The first physical barrier is comprised of corneocytes tied together by desmosomes and other linker molecules. And in between these bricks, there is a mortar of very complex lipids and ceramides, which fill all the gaps and confer really essentially the barrier function, particularly with regard to water loss. Filaggrin is a key protein in this, which I'm going to be talking about through the talk. It gets degraded in a post-translational modification way. The corneocytes become dissociated from themselves, shedding through proteases as the epidermal barrier matures and turns over every 28 days or so on average. There are preformed cytokines, particularly the interleukin family cytokines, interleukin-1 alpha and others, and these are like little balls of antibacterial and antiviral protection, part of the innate barrier that's there. And there's sometimes overlap between what we consider the innate immune barrier and the physical barrier because these components are so intricately linked. There is a second immune barrier, and that's between the layers of the stratum granulosum 1 and stratum granulosum 2. This is Lisa Beck's slide. And in that granular layer of SG2 is the tight junctions. And underneath the tight junctions, there is generally no Langerhans cells or antigen-presenting cells extend beyond those in a resting state. When the skin barrier is healthy, when the skin is not activated, Langerhans cells do not extend beyond that, and neither do IDEX or other antigen-presenting cells. However, when the barrier is activated, when it's damaged, Langerhans cells stretch through the tight junctions dissociate, open up, and Langerhans cells, through their pseudopods, can sense the outside environment and then present those antigens or allergens. And it's, of course, very important for allergen sensitization through the skin. So allergens can be picked up by antigen-presenting cells, presented to the adaptive immune system, and adaptive immunity can be driven from that. So that's a second immunological barrier. In atopic diseases, including atopic dermatitis, there's the chicken and egg debate. Well, which comes first? Is it a disrupted barrier as a primary mover, or is it a disrupted immune system, or what way do these work together? And there are some clues, and it's still a very complex interaction between the immune system, the skin barrier, and the microbiome. There are some clues that in primary epithelial defects and from genodermatoses are often associated with significant atopy. So these are patients who have very profound barrier dysfunction due to a single gene and yet have all of the allergic manifestations. For example, ectodermal dysplasia, it's a structural defect in the epidermis, in the barrier, not an immune defect, but you get all of these consequential immune defects as a result of skin barrier disruption. Netherton syndrome, again, this is another primary barrier defect because of dysregulated proteases. The regulator of proteases called leaky, encoded by SPINK5, is absent, so proteases run amok. They dissolve. You'll remember from the early slide, stratum corneum going through that proteolysis and the shedding of the skin through the epidermal barrier maturation. In this case, it's far too rapidly processed because there's untrammeled protease activity, and that gives you Netherton syndrome associated with multiple allergies, even down to eosinophilic esophagitis. Other linker proteins, these are corneodesmosins, linking the corneocytes in the epidermis, in the stratum corneum together. Defects there can lead to severe atopy and skin barrier defect. That's a peeling skin disorder due to corneodesmosin mutations. An absence of these gives profound allergic defects. I'm going to move back to filaggrin because I mentioned that was a protein of significant interest in this space, and one of the reasons it's of interest is it's so abundant in the stratum corneum. It composes about 70% of the dry weight of the stratum corneum, and here it's stained green with the nuclei blue and the basal keratinocytes red. That's keratin 5, a basal keratinocyte keratin. And you can see just how profoundly and heavily expressed filaggrin is in the stratum corneum. Filaggrin has substantial post-translational modification as we go through that process. We take to the basement membrane, the stratum basale, stratum spinosum, stratum granulosum, and the stratum corneum. We just have a look at what's going on. Well, filaggrin is expressed in the granular layer. You'll remember the granular layer. I mentioned that underneath the stratum granulosum 2, there was the tight junctions running through that, and underneath that and above it, you have filaggrin expressed in keratohyalin granules. Here, keratohyalin granules undergo the first post-translational modification, which is dephosphorylation, and then chopping up by SASPase into filaggrin monomers. Filaggrin monomers then in the stratum corneum bind keratin filament bundles, tighten them together, and form a really good physical barrier. That gets broken down by bleomycin hydrolase, also with caspase 14 and captain 1. You can see how sophisticated this is, and it's a big adaptation to our terrestrial life, essentially, that we can live on land. We need this structure to keep us from dehydrating. Bleomycin hydrolase and caspase 14, we break down into natural moisturizing factors, PCA and UCA predominantly. These are filaggrin breakdown products, and they make the stratum corneum supple and flexible. And that's so if we look at filaggrin mutations, they were identified 16 years ago, but we now have a real depth of information about filaggrin mutations. The ones that cause disease are stop codons or loss of function mutations. So if you have one of these, then you only make 50% of the amount of filaggrin, and there's only 50% of the amount of filaggrin available for post-translational modification too. And you can see that in Europe and in Asia, and there's other data from Africa, you have very ethno-specific mutations or region-specific mutations that occur again and again and again. We don't know why these have been preserved in through to modern life. Is it a vitamin D advantage? Is it an antimicrobial advantage? We're not sure, but these mutations run at about 10% of populations everywhere outside of Africa in all of the populations. So they're there and they're abundant, and they cause a very substantial disease burden. If we look at the burden of carrying a single loss of function mutation in filaggrin, you can see the odds ratio of, for example, peanut allergy, and that's probably because of percutaneous sensitization is about 5 times the background population. The overall risk of asthma is about 50% increased, although only if you also have atopic dermatitis. and the odds ratio for atopic dermatitis is more than 3 times the background population. So these are very substantial population risks conferred by a skin barrier genetic abnormality. There is, of course, a second hit on filaggrin in atopic dermatitis and in atopic disease in general, and that was identified a long time ago by Don Young, looking at IL-4 and IL-13, particularly when they're expressed together. This is in vitro data showing filaggrin expression is rapidly downregulated by 4 and 13 co-expressed. Really elegant paper. And we've seen subsequent papers that show IL-4 and IL-13, IL-17 and IL-22 all downregulate filaggrin expression. So there's multiple immune regulation of filaggrin expression too. So people who have these pathways switched on, and we know that they are in atopic derm, particularly IL-13, but also 17 and 22 to much less extent, they will all downregulate filaggrin expression and cause a weakened skin barrier. We know that, and this is work from Sanya Kedjic and Granio Reagan and my group, we know that in people who have severe atopic dermatitis, their natural moisturizing factor is rapidly downregulated, even in the presence of no filaggrin mutations. So there's a second hit that applies to everybody who has severe atopic dermatitis. They will downregulate filaggrin through immunological mechanisms. And this is it in a simple way. You have a defective barrier, you get Th2 stimulation, and type 2 cytokines, particularly 13, downregulate filaggrin and other barrier genes. So you're in a vicious circle here in atopy. Filaggrin also modifies other atopic dermatitis genotypes as well. So we know that if you have early onset in the red bar here, early onset and persistent atopic dermatitis, you're much more likely to have a filaggrin mutation. And conversely, the true, if you have filaggrin mutations, you're much more likely to be on this pathway, the red pathway, than to have an early onset and rapidly remitting and continuously remitting atopic dermatitis. Sites of predilection are also important. So if you have a filaggrin mutation carrier, it's going to be the areas that are exposed to the environment, because the skin barrier is not so robust and resilient against cold weather, pollutants, allergens and so on that are exposed. So the hands and the cheeks are going to be preferentially affected in filaggrin mutation carriers, and that's been elegantly shown by Hans Biskert's group. So if you have filaggrin and you have atopic dermatitis, you're going to have more eczema herpeticum. It's going to be more severe and persistent, more likely to have asthma, more likely to have allergies, and more likely to have dry palms as well. So there's a significant modifier on the disease as well. How does haploinsufficiency lead to the barrier defect? Well, there's a number of ways that it does this. This is a scanning electron microscopy here of the stratum corneum. It's lovely and smooth, like tiles on the floor. But if you have a filaggrin mutation, these gaps open up dramatically. This is Peter Elias's and Matthias Smuth's work, just showing that tracer proteins go right through the stratum corneum much more easily. And that is showing that in addition to having an abnormality of the corneocytes, that having a filaggrin mutation affects the lipids within the stratum corneum also. And that, remember, the lipids confer much of the barrier, the mortar around the bricks confirms much of the barrier function. And we've seen this very elegantly with work done here on scanning EM. If we look through it with atomic force microscopy, it's at the corneocytes, we can see in filaggrin mutation carriers, the corneocytes are pimpled. They're like little multiple pimples on the surface of the stratum corneum, like stickle bricks, and they make the stratum corneum much less effective as a skin barrier. And we can see this really beautifully in some of these atomic force microscopy images here. If we stay with immunogold, we can see at the tip of these little stickle prominences is corneodesmosine. So corneodesmosine is a target for Staph aureus, and this is one of the reasons that we get more infection in stratum corneum of atopic derm patients with filaggrin mutations. So rather than being lovely and smooth, we have a stickle brick type approach, and the surface area is much bigger for Staph aureus to adhere to as well. And we've actually done live experiments with this, with live Staph aureus on the tip of the atomic force microscopy probe, and we can see this is where the Staph aureus in the bottom left, this is Staph aureus adhering to a filaggrin mutation cornea site. It's just incredibly adherent to it, and it's just ideal for staph colonization, a huge feature in atopic dermatitis. And remember, filaggrin is lowered because of genetics, but also because of the type 2 signal. So here we see the multiple consequences of filaggrin mutations: skin surface abnormalities, pH, and the rugose surface, in decreased corneal desmosine density and decreased tight junctions. We see the interstratum corneum, decreased keratin aggregation, which means more leaky skin, and in the granular layer, we don't really know what the function of filaggrin is yet, still not understood. So remember, AD has its origins in early childhood, so it's worth looking at barrier maturation in healthy kids. And what we can see here, we're measuring natural moisturizing factor as it's broken down postnatally in age in weeks, up to 4 weeks, and then up to 72 weeks. And what we see on the cheeks, I'll just draw your attention to the cheeks really here in the top left, is it takes a very long time, up to 3 to 6 years, for the cheek is still maturing, and that's really important, particularly for allergists. This kind of slow maturation of the cheek that we've seen here. And the slow maturation of the cheek really allows for a perfect storm. And we know from Gideon Lack's twin allergen hypothesis that food taken orally is tolerogenic, through the skin it's allergenic. And we can see through our studies that there's delayed natural moisturizer maturation in the cheek. It's got low stratum corneum adhesion and low corneocyte maturity. So it's a real easy way to penetrate through the cheek and through the skin and present allergens to those antigen presenting cells I showed you at the top of the lecture. And we see the Yamamoto sign here, where people have, or young babies have, these very inflamed cheeks, most likely because that's the weakest area of their barrier. And if you put a food allergen on top of that, it's just open access. It's the highway through to the immune system to provoke allergy. What about going from an aqueous environment to a dry, arid environment? The biggest environmental change any of us will make in our lives is from the inudral to exudral environment, where it's extremely dry, and the skin has to adapt to that. And we've known for over 30 years in neonatal rats that there's a very profound effect on how filaggrin is dealt with postnatally, and really within hours of birth, filaggrin starts to break down very rapidly. There's a classic experiment by Harding in the mid-80s, which showed that just in cesarean section rats. But interestingly and very relevantly, we can show that also in humans, obviously using different techniques. This is work with Jonathan Hurriton and myself, looking at days after birth. And what we're looking here is that using a Raman technique, looking at natural moisturizing factor as it increases immediately after birth. And we know that about 5 days after birth, NMF on the arms, for example, has really rapidly undergone change because our skin senses that we're no longer in an aqueous environment. It rapidly processes filaggrin to try and make that adjustment to keep moisture in the skin, to keep the skin barrier intact. And that also gives us a clue as to when potentially is the best way to intervene to prevent atopic dermatitis, which leads us on to the Stop AD study, which we published just towards the end of 2022. And this was an intervention trial. There'd been many intervention trials to prevent AD. We did a slightly different one. It was a very short intervention trial. It was just 8 weeks with an emollient that had ceramides and other specialized emollients. And we went in as soon as after birth as possible, with up to a maximum of 4 days because of what we've shown you with the filaggrin degradation and those profound changes immediately postnatally. We treated up to 8 weeks and we followed at 6 months and 12 months. And what we found was a really profound decrease in the relative risk of atopic dermatitis. If we look at the cumulative AD risk in the intervention arm, it's favored at both at 6 months and at 12 months. And if we look at people who had persistent AD at both 6 and 12 months, the difference between the intervention arm and the control arm was profound. So despite the frustrations of very large intervention trials, we're showing that there may be potential for a short-term emollient intervention. Of course, it needs to be replicated, but it's quite exciting, and it shows the advantage of getting in extremely early, potentially to prevent AD and subsequent allergies, perhaps in high-risk kids. Just to conclude, the skin barrier is complex. The defects are multifactorial. They've got microbiome defects, there's lipid defects, there's structural corneocyte defects. In AD, filaggrin deficiency is a risk for it, but also a major disease modifier. Type 2 cytokines and others, 17 and 22, cause a secondary decrease. Filaggrin deficiency has profound structural defects on the stratum corneum. And it has differential regional maturity with the slow maturity in the cheeks, which potentially explains allergy in those under 1. And early intervention continues to have promise, but there's still many unanswered questions, and our studies don't answer all of those. These are the many people involved in the data that I showed you from the various centers and collaborators that I have. And these guys would just like to thank you for continuing to be interested in their skin and their well-being. And thank you very much for your attention.
Well, I hope the message that gets back to Dr. Alan Irvine, is that he gave an excellent talk on the leaky barrier. Not that I was unable to introduce him because I was trying to move us back on schedule. I'm proud to say that all of the rest of our speakers are live here today. And I'm going to move on to introduce Dr. Amy Peller. She is the Walter J. Hamlin Professor and Chair of Dermatology, Professor of Pediatrics, and Principal Investigator of the NIH-funded Skin Disease Research Center at Northwestern University Feinberg School of Medicine. She's been an author of more than 500 publications in landmark trials involving inflammatory skin disorders. Her laboratory focuses on nanotechnology for therapeutic delivery, diabetic wound healing, and cutaneous innervation. And Dr. Peller is going to be talking to us about clinical and molecular differences in skin and blood of children compared with adults.
Thank you so much, Ellen. Well, we've heard quite a bit already about this, so I'm going to try to make this practical and maybe give you a little bit of additional information. Let's see if I can. I need advancing. Oh, there we go. Great, I'll just do that. Or use what? This? Okay, let's try this. And then this. Okay. Great. All right, I will say that I really am not talking about anything that has anything to do with commercial, but I've been an investigator and also a consultant for several companies as well. I think that I don't need to tell this group about atopic dermatitis and how it really is primarily a pediatric problem, although from the work of some of the speakers here, Dr. Silverberg, Dr. Simpson, we know that we're seeing a lot in adults as well. And this is just to remind you that this is a very heterogeneous disorder in terms of its natural history. The majority of many of these children that we're seeing, particularly those with mild to moderate disease, will have a quiescence in their atopic dermatitis fairly early on in life, whereas we can see others that maintain their atopic dermatitis or even develop it even as late as those that are not shown on here, but 65 years and above. And we know as well that in some studies, about a third have moderate to severe atopic dermatitis in this age group. A more recent study that came out actually showed that even more have moderate to severe disease. And we also know that as we go up in age, those who are adolescents, we see a greater number that tend to have more severe disease, and even more so than in adults. So a lot of the younger children will have milder disease, but of course so many of them have more severe disease, and that's where we've put a lot of our attention right now in terms of how to help with these patients, other than the immunosuppressant drugs that we've had for years. Age-related morphology and distribution, I think we're all aware of this, and we heard a bit about this as well from Dr. Silverberg. I will say that I think that we need to be asking questions about why these are, and we've heard some answers today, and we need to keep thinking about these. Why is it that the babies don't have involvement of the diaper area? Although, if you've ever had a baby with atopic dermatitis, it's not uncommon when you take off the diaper to see them start to scratch immediately, but yet we don't really see it. Is that because of the inability to scratch? Is that because of the nice humid environment? Is that because we're not seeing exposure to potential triggers that may be in the environment as much, or maybe it's even the concept of the microbiome being a little bit different in that area, perhaps again related to the occlusion. I'm fascinated by the findings that we just heard Dr. Irvine talk about with the filaggrin and the cheeks and that slower development of the barrier in that area, because I think maybe it's starting to explain to us why we see so much involvement in infants of that cheek and chin area, and maybe not so much later where we have more of that immediate periorbital and perioral area. And so we have to start thinking about the pathogenesis of these various differences, because I think that they will help us then to know how to treat these areas and maybe how to prevent. And we'll talk a little bit about the cheek area and food allergies, of course, which we also just heard from. Why do we see more exudation in this young age group? Why is there so much more edema? Why is it so often that these children are mistreated as having infection when in fact it's really just exudation, particularly in this facial area that's mistaken for infection? And why do we see that accentuation of the fold areas, which, by the way, we can see quite a bit of, and even in the youngest infants, as you well know, but certainly is the hallmark of where we most commonly will see the involvement as children get older, and certainly in adults with the antecubital and the popliteal area involved. And I would say, John, and then I see a lot of involvement of the hands in little babies. And of course, we know that and what happens on the face is a lot of irritant dermatitis component, because these babies, of course, get all this liquid and irritating saliva and foods sitting on their face, and their hands are in their mouth, and that's where we often see it. So some of these age-related differences are due to basic science, as we're learning, but others due to exposure to the environment. Now, we talked about pathogenesis. You just heard a whole talk about pathogenesis. And just reminding you that our focus has largely been on the immune system and the shifts towards the Th2, Th22 immune system. Of course, the barrier defects, whether they're primary because perhaps someone has that deficiency of filaggrin as a genetic abnormality, by far the most common genetic association with atopic dermatitis, or much more commonly, whether it's secondary to the increase in these type 2 cytokines, which we know can drive down so many of the barrier protein expression and the lipid expression as well. Regardless, we know that when we treat adequately, as you saw from Dr. Gutman's talk, we correct these, and the same thing is happening in children. Of course, we're starting to really understand that interplay between the environment and the barrier, the environment and the immune system. And then, of course, we know downstream from that very central Th2 cytokine abnormality are all of these various pathways that signal through Th2, Th22, and all these other pathways through the JAK-STAT. And this has all come to play, of course, when we're thinking about therapies. You've seen some of these pictures already. I'll very quickly make some of the points that you heard. In our studies looking over different ages at skin biomarkers, I want to recap that what's, I think, most important and most practical is that the same abnormalities seen with Th2 and Th22 in both non-lesional and lesional skin are seen across the various ages. And that tells us that the therapeutic approaches targeting type 2 cytokines should work universally. And I don't have to tell you that that's what's being played out as we go from adults to adolescents to children to even very young children, that we're seeing that when we're suppressing this exuberant type 2 immune response, there is good improvement. You heard a bit about type 1. I think this is really interesting. In all of our studies with young children, we saw this deficiency in the blood and in the skin of type 1 immune system. So very reassuring to hear that there's not this big suppression of type 1 immunity from dupilumab. I think that's something we're going to have to keep an eye on, though. It'll be interesting, for example, with more global inhibition, what's happening with type 1 and how important is that, for example, in the infections that young kids are getting, and particularly not just bacterial but viral infections. You also heard a little bit about the type 17 immune system being increased when we look in general at children. Th17 responses are increased. That makes sense because they're learning how to respond to the environment, and these Th17 responses are very much how we respond to organisms in particular in the environment. And we do see that even more so as an even brisker response in the children with atopic dermatitis. I think when we think about children versus adults, I'll throw something new in here, and that is we're really having to think in a different way about some of the therapies. So consideration with biologics, for example, seemed very safe. They're very targeted. But we know that now that we're down, for example, with dupilumab to 6 months of age and above, we have to start thinking about live immunizations. And I just yesterday got another email from a pediatrician saying, okay, I want to give live immunizations. This patient is on dupilumab. What should I do? And we can't always give them before we start the dupilumab. So I think this is going to be something that we'll learn about over the next few years. There has not been any trial about this. There are some trials that are starting to try to at least gather more information, and we're in the pediatric dermatology community trying to gather information, as I'm sure in the pediatric allergy community that is also happening, because we've got to learn as soon as we can about the safety of giving live vaccines, ideally being able to just give the vaccine and not stop the medication for 4 weeks and then wait another 4 weeks till after the immunization is given. From a theoretical standpoint, it is not a risk, but I think this is something we're going to have to watch carefully. And given what we know as well about long-term rubella in patients who are immunocompromised, it may take a while before we figure this out. But I think some short-term trials and just collecting a lot of data on kids who happen to get it, which is happening all the time, and so far no problem at all, is what we're going to need to do there. We don't know the impact on the developing immune system. We don't think that the Th2 arm is very important, but that's something that we're going to have to be watching carefully. And again, there are studies that are trying to look at that. I think one of the biggest struggles for those of us in practice is how to deal with the pain of injections. And you can reason with an adolescent, even though they may not like it, they accept it, they'll do it. But then you start to get to the 6 to 11-year-old group, and you've got kids who will express their mind and will tell parents that they're not going to do it. And when it becomes a huge struggle, after a while, it's just too hard. We have all kinds of tricks, and I didn't put it into this talk, but all kinds of tricks, especially with distraction or trying to numb the area, and the way you hold the child, etc. But at the end of the day, for any of you who've had these parents come into your office to be able to give an injection because even every 4 weeks it's too hard, after a certain point you say, enough. What are we doing to the relationships within this family? What are we doing to the child? And then there are some, even young babies, they may cry, but it's very short-lived. And it really, in many ways, depends on the parent and their ability to manage this. I think that the very exciting possibilities that we also need to consider when we're thinking about children versus adults is how we can leverage our new directions in therapy to make changes in the course of the atopic dermatitis, changes in the risk of comorbidities, and how we can also be predicting with potentially different predictions in children versus in what we might be thinking of in adults. I'm going to just show this again, too, to talk about the blood versus the skin here, because we've also looked at these, as you heard. I again think it's very interesting and requires more thought to think about why this Th1 interferon gamma deficiency is occurring, which we're not just seeing in the skin, but also in the blood, and how it may be having an impact on infections. I thought it was also interesting when we ran these studies that we see a difference in the expression of these various cells by flow studies in terms of the subsets of cells as we look at the very young children as opposed to as we're looking at different ages. Now, all of the babies in here were ones that we collected who had developed their atopic dermatitis within the previous 6 months. And they were almost all 2 years of age and under. So we're talking about very early atopic dermatitis, young children. And what we saw when we looked at the flow studies is that the T cells were expressing this increased number of T cells with IL-13 on their surface. And these were CD4 positive, CLA positive meaning the skin homing ones, going back and forth between the skin and the lymph nodes. What we did not see were other subsets that were seen in adults. The CD4 positive, CLA negative subset, the CD8 positive subsets. And so it raises the question of there is this progressive expansion in the increases in frequency of a variety of different immune subsets. And what does that mean? Does that correlate with the development of other allergic disorders? Is it something that has to do with maturation or chronicity of disease? And that remains a question. You heard a little bit about the deficiency of proteins of terminal differentiation. I'm not going to go over that. The progressive reduction in tight junction components that were discussed by Dr. Irvine as well, and the Th2 cytokines that suppress the expression of these various proteins. And I'm just going to show you this is some work that Emma and I did in the past with the tape strips, and I can't say enough about tape strips for kids. You know, that's just exactly how we want to move forward in doing further studies. But you can see here with all of these various proteins of differentiation that there's a serial decrease when we're talking about really healthy skin versus the non-healthy but non-lesional skin of kids with atopic dermatitis versus the lesional skin. And just to remind you that these kids all have that leaky barrier. If we look at transepidermal water loss, the average in these children was 4 times what we tend to see in normal. And as you heard from Dr. Irvine, the cheeks being the leakiest barrier. Now, since a lot of what I'm talking about was really relevant to others, and I just wanted to give you a capsule summary of that, I'm going to spend the rest of my time talking about something that I noticed Dr. Irvine did not spend much time on, and that's about the lipid barrier in young children. And all of the studies I'm going to show you were done in young children using tape strip samples. And I'm bringing this up because we haven't paid much attention to the lipid barrier, but you are going to see a lot more coming out of that, because I will tell you that there are studies not just that show the importance of the barrier and ceramides in particular in atopic dermatitis, but also showing that when you treat effectively, you improve the barrier, and perhaps just as important, that we're starting to get more evidence that we can tape strip and look at TSLP, IL-13, for example, in tape strips as predictors, but also looking at a variety of different lipids. So I'm going to give you a little bit of a crash course on lipids and just say a little bit about what we've been learning about these. So in the skin, we have very unusual lipids. And we can talk about the big 3 being the free fatty acids, the cholesterol, and the ceramide. And of these 3, it's probably the ceramide that's the most important one in making this barrier, and that makes up 35 to 50% of these various lipids that we can find in the stratum corneum. Now, I don't know what you know about ceramides, but I remember a time before I started working more with them when I thought, oh, ceramides. Oh, here's a moisturizer that has ceramides in it. And ceramides are deficient, so that must be good. But the stratum corneum ceramides are really very complex. If you look at traditional targeted lipidomics, not very fancy technology, there are about 300 ceramides in the stratum corneum. We've used an untargeted approach that's similar to some of the untargeted approaches for looking at proteins and and RNA, and there we just find 616 unique unbound ceramides, and that's not even the bound ones bound to the cornified envelope. If you take a more exhaustive approach that's very, very labor intensive and costly, as was recently done by Suzuki and that group, they found 1,327 unbound and 254 protein-bound ceramides. So, complex. When we talk about ceramides, we're talking about two lipid groups that come together. One is the sphingosine base, as shown in red, and the other is the fatty acid, as shown in blue. What is very unique about ceramides in skin is they have greater complexity than almost any other tissue. And there are very long, up to 27 carbon, we might say. Everybody has different nomenclature about how many carbons is ultra long versus long, but ultra long and very long are what we see that are unique in skin, versus up to about 24 carbons in the ceramides of most other tissues. There are also many odd-numbered carbons in skin. This is very unusual as well. And then a variety of sphingosine bases within that red part that are quite unusual also in skin. Large numbers of phytosphingosines. Phyto comes from plants. We find them a lot in plant-derived, but not so much in human tissue. 6-hydroxysphingosines, another group that there's quite a bit of it, and another group called dienes. And we've even found one through the untargeted approach that's not been described before. So what are some of the lipid abnormalities? Well, huge deficits in the major ceramides. As shown here using an untargeted approach, 84% reduction in the total content of ceramides in lesional skin. And that very much disrupts the lipid ordering that makes for a functional lipid barrier. We've heard a lot about fatty acid chains, and you're going to hear a lot more about this. Relative increases in shorter chains, those that have up to 24 carbons, and marked decreases in the ones that are a bit longer. And we know why this is. This is probably due to these huge reductions in the expression of two genes in particular that we have found repeatedly in our transcriptomal studies, and others are showing as well. One of them is called elovil-3. Elovil, that's an elongase. And by being deficient, this is specifically needed to make these very long chain ones. But the other is a deficiency in something called fatty acid 2-hydroxylase, and that allows the hydroxylation. So what you get if you don't have enough of that is a lot of what are called the N, or non-hydroxylated ceramides. And so we're having a relative increase in these non-hydroxylated or N-ceramides, and we're having the decreases, particularly in these very long and ultra-long ones. Now, we can do this with tape strips, which makes babies very happy. And so this is just showing you we can do RNA-seq, and pointing out the deficiency. This is a volcano plot. On the blue is deficient, so the deficiency of the elovil-3 and the FA2H just from tape strips, as opposed to what I'm showing you above, which was from biopsy and several years back. And we can also know now from some additional works that, at least with elovil-3, those key players, interleukin-4, interleukin-13, are now known to inhibit that. So we start to put this together as a picture. We also know, this came out very recently from dupilumab, that there is an increase in these ultra-long chain, very special, what are called EOS ceramides. This is for the esterified omega ceramides, also called acylceramides, that are very unusual in skin. And these are thought to be the primary ones at the very beginning, where you have the link to the cornified envelope that then starts as the template on which you have these other lipid layers that form this lipid barrier aligning. So one thing that I will tell you is that sphingosine bases, well, what do we know about them? They've been very poorly studied, but indeed when we look at our volcano plots, there are two very decreased enzymes that are important for making these sphingosine bases. And when you look at the sphingosine base component, we have something in parallel to what we see with the fatty acid one, with the increase in the shorter chain ones, the reductions in the longer chain ones. And we also see that the bases, these unusual bases that are in skin, the phytosphingosine and the 6-hydroxysphingosine in particular, are reduced, and there's an increase, as shown here in purple, in the lesional versus control, of sphingosine itself. And sphingosine itself can be deleterious to cells. So this is a whole new area of investigation. These, by the way, have not yet been published, but I'm telling you that this is another area of investigation we're going to hear more about. And we know that the chain length, which is affected by what I've circled here in blue in that volcano plot, these various enzymes that are part of what's the very beginning of the de novo ceramide pathway, and also these sphingoid base shifts moderately correlated with AD severity. There was a paper that just came out this year suggesting that the sphingoid base change at 2 months was the best predictor of the development of atopic dermatitis in infants when these were done before the occurrence of atopic dermatitis. TARC was another good one. And I think we're going to see another paper coming out very soon that is going to show some other lipid abnormalities, including getting into sphingomyelins, that are going to be good predictors. So more attention on the lipids as we move forward. Now, I'm just going to say a little bit about barrier, because I think that we're going to hear a little bit more about that to come, and I don't want to steal that thunder, and we also heard a little bit already. But I do want to mention that emollients are not just sealants, and Emma Gutman's group showed many years ago that just looking at petrolatum on atopic dermatitis skin, on healthy skin, actually increased innate immunity, increased the expression of antimicrobial peptides, increased the expression of filaggrin while reducing T-cell infiltration and the stratum corneum thickness, at least when this was done in adult non-lesional skin. It also is a great potential vehicle for delivering deficient lipids. So we all know about these trials. I think you're going to hear a little bit more about them, so I don't want to spend too much time other than to reiterate that there were some really exciting early trials coming out from the US and the UK, as well as from Japan, suggesting that early moisturization could prevent atopic dermatitis, but then the larger prospective studies didn't show it. We were all very bummed out by that. And I don't want to take a lot of time, so is that coming up in the talk that's coming up on prevention? I don't know where that speaker is. Not much? Okay, then I'll mention it. So just to remind you that the BEEP study, the Barrier Enhancement for Eczema Prevention, a large study in which daily emollient was used for 1 year versus standard skincare advice, that there was no evidence of protection against atopic dermatitis development at 1 year or 2 years. It was even followed through 5 years. There was a non-significant increase in food allergy with emollient use. I'm going to mention that more in a minute, at 2 to 4 years, but not a cumulative by 5 years. And then a significant increase in skin infection in year 1 was notable. And that does raise the issue of the potential that when we're using emollients, we do have to be careful about the fact that there's colonization on these children's skin. And especially kids who have crusting or have recurrent infections, I always suggest that one doesn't keep going back in with the hand to the face or the other areas, then back into the emollient. You have to realize, and there was a study many years ago actually showing that many of these emollients grew out bacteria. And especially if you don't keep it in the refrigerator, just go in with something clean each time you're going to go in to take from the emollient. And so maybe that had to do with that. Preventing atopic dermatitis and allergy in children, the Prevent All study in which facial emollient and bath oil additives were used versus early introduction versus both versus just standard with none of these. There was, again, no evidence of protection against atopic dermatitis at 1 year in any group. A reduction in the combined intervention group by 36 months, and a reduction in food allergy at 36 weeks in the group with the early food introduction versus the standard. And interestingly, the emollient without early food then was also the same as the standard. So one hypothesis may be that petrolatum-based emollients are not enough to prevent the occurrence of atopic dermatitis because they don't replace the molecular barrier defects that we're seeing. So should we be supplementing with filaggrin for those with filaggrin deficiency, which, as you heard, low THNR, natural moisturizing factors, it may be in the future an easy way to check that. Should we be supplementing with specific ceramides and ceramide precursors that are deficient? Do we want to identify these children early on in using a mild anti-inflammatory agent, presumably a non-steroidal, as these are coming out and available? And again, this is Dr. Irvine's trial, Stop AD. And I do want to mention that in this trial, the emollient that was used for those 2 months was an emollient that had a ceramide in it that may be particularly useful here. It has a lot of that phytosphingosine in it. So maybe that also had something to do with it. Maybe it was the short-term use. And I also want to ask the question, can facial moisturizer actually increase the risk of food allergy? I think we're going to try to see this a little bit more with these. There was a trend towards that. There was the EAT study that you're all very aware of that showed a significant dose-response relationship between moisturization and the development of food allergy in infants without visible AD at enrollment and in all infants regardless of the presence of AD. So that's kind of worrisome to me. I've been telling people for years, make sure to get that emollient on, especially on the face. Make sure you get it on before the meals. We got to protect. We've got to make sure that they don't have that contact with the food. But I will also tell you, and we know this in dermatology circles, that when people have done studies where they have first put on an emollient and then topical steroid, or when they've put on this topical steroid first and then the emollient, which you would think would be the way to go if you're trying to have a protectant and nothing would come through it, there really hasn't been that much of a difference in these studies, suggesting that maybe it's not really a barrier against things that are small and can get through. And I think we have to keep that in mind too. Maybe it may even prove to be an adjuvant. So I'm waiting to see more about that, but I want to make sure that over the future, moisturizer is not proven to be a conduit, and I'm starting to rethink when I'm telling families. So in conclusion, many of the atopic dermatitis pathogenic and morphologic features in adults are also seen in children, translating to shared responses to targeted therapy. We're starting to understand differences based on regional barrier differences, exposures, and biomarkers linked to phenotype. The ability to tape strip painlessly, you're going to see a lot of that because it provides skin material from the upper epidermis, where all the action is, for big data analysis when we're talking about the barrier. Understanding basic biology and considering predicted biomarkers in pediatric patients will largely be from the tape strips. But our goal overall is prevention in children, not just prevention of the atopic dermatitis, but reduction in severity, prevention of comorbidities, especially allergic and the neuropsychiatric that we know also are at risk. Emollient use is not looking good, but I think we're still at the beginning. And I'm very confident that we'll figure out how to prevent through applying things topically in the future. With that, I'm going to stop, and thank you.
Thank you so much, Dr. Peller, for a very informative talk and clinically useful as well. We're going to move on to Dr. Carolyn Jack. Dr. Jack is an assistant professor at McGill University and a junior scientist at the Infectious Diseases and Immunity at she's co-founder of Eczema Q, an award-winning mobile health application. And she comes to us from McGill. Thank goodness she made it in here. And she's going to be speaking to us about infections in atopic dermatitis and implications for therapy.
Great. Thank you very much. It's really an honor and very exciting for me to be here. So thank you very much. I'm a junior scientist, and I've got this wonderful topic on infections in atopic dermatitis and the implications for therapy, which, as we'll see, is a really remarkable topic to be thinking about and to be following over the coming years. Here are my disclosures. So as dermatologists at these tertiary care centers, we're often, the last resort for these adult patients, and this is primarily my focus. And we see patients just, essentially walking petri dishes, oftentimes, where you can smell the odor, the staph is very, very present. And so we've all known for so long, it's been so long recognized that staph has such an important role to play in this bidirectional relationship with atopic dermatitis. And yet we don't understand very much about it still. There's a mountain of new knowledge being generated, but there's a lot still to explore. So the course outline for today is really to sort of talk about how atopic dermatitis patients really do have an increased infection risk. That entails genetics, skin barrier function, and both innate and adaptive immune effects. We know that there's a really complex host and pathogen dynamic there, and that can influence our endotype, which I'm sure we've heard about already, so the immunophenotype of these patients and how they respond to treatment. There's an overlap with primary immunodeficiency disorders, which we'll talk about briefly. And overall, we need to think very carefully about how we manage infections and infection risk with AD patients. The vaccination considerations, you'll probably be hearing about in more than one talk. Hygiene and prevention, we've just had some of that come through with Dr. Paller's talk, and how we think about the impact of medications on that infection risk. At the end, we have this, yin and yang of Staph aureus in this disease, and there's a very special relationship there between this bacterium and this skin condition. And there is a mountain of very exciting and really revolutionary work happening now that we can do so much with our omics data that is probably beyond the scope of what we can cover here within this short talk. So within this complex ecosystem of atopic dermatitis, here we're focusing on what happens at the skin surface with the host interacting with this pathogen in the context of many, many other triggers and allergens floating around. And the hope here is that we can understand the role of that microbiome on the skin surface and how to diagnose and treat these infections in particular, overall to improve our management of our patients. So when I first got this talk, I was very excited because it's a really interesting topic for me. And then I thought, oh my gosh, what did I do? This is an enormous, enormous field full of very exciting global research through staph vaccines to ecosystems, global ecosystems at the surface of this earth, how we live with them, the ecosystem on our skin, knowledge about how staph evolves within our own host, how the clones sort of spread across our skin ecosystem, and then on top of it, how this complex immunomodulation and immune systems interacting with that microbial ecosystem, and the metabolism that is shared at this skin barrier surface, and then getting into that metabolic, microbiology and very complex biochemistry, going all the way down to the Krebs cycle. You can see that the scope of this topic is huge. We want to start talking about, at the beginning, what we know. We know that AD patients have an increased infection risk. It is a complex disease. There are multiple risk factors, and we know we're not unique in just talking about these microbial triggers. But here today, we want to think about how those microbial triggers interact with this defective skin barrier and interact with the allergens and help to promote the deviation in the immune access towards the Th2. So atopic dermatitis is a complex trait. It's highly hereditable, but it also has a lot of missing heritability. And that complex trait of genes interacting with the environment leads to a huge amount of heterogeneity, and that leads to these endotypes. And we do think that staph can play a role in driving that. Many of the selected genes for atopic dermatitis you're going to hear about in other talks, but we're learning about how these immune genes, and in particular the ones that drive host responses to these microbes, can play a role. We know that heterogeneity leads to a lot of diagnostic difficulty and management difficulty as we're managing skin that is essentially chronic and lichenified, all the way through to subacute on chronic, through to really heavily impetigenized skin. And so how we're managing these conditions in each individual patient does need to consider the burden of the microbiome because it can play an important role. We know that the dynamics between those two really could influence how our medications are working, and also can contribute to the etiology, so at the beginning, why this disease occurs and how it occurs, and in particular, how we can learn about its prevalence and incidence in the coming years across the globe. So overall, we know that atopic dermatitis is associated with a skin infection in particular. We can know it's readily isolated in 75 to 90% of AD skin, and it's armed with this huge armamentarium of virulence factors. So it has everything it needs to induce inflammation and damage of the skin. It is also a very complex immunoevasive bacteria. It is the cause of the most serious infections before COVID came along for hospitalization, so it's an enormous pathogen, but it is able to live with us so successfully. We know that the ratio of Staph aureus to other commensal species on the skin can actually distinguish a household that has atopic dermatitis from one that doesn't have it. We also know that HSV infections appear to be more than twice as common in AD patients compared to the general population. And we see that now in these cohort studies that are starting to accumulate. We also know that these herpes virus infections, including eczema herpeticum, which we'll get into in a bit more detail, are really more likely to occur when the atopic dermatitis is poorly controlled. We know that many of the phenotypes of our disease overlap with, for example, impetigo. And we see that superimposing itself over more traditional forms of atopic dermatitis. When we see patients, we have to consider an ear like this could be a cellulitis. But on the right, we can consider also that this could be a primary immunodeficiency. What's very interesting to consider is the fact that many of these monogenic primary immunodeficiencies do also present with eczematous skin conditions. When we want to recognize what is dangerous, what is a red flag with these patients, eczema herpeticum is numero uno. And so when we see these punched out ulcers, pathognomonic for an atopic complication, typically with HSV, but often with Coxsackium. And we know that the risk of these herpes viruses can lead to serious complications. In this study that Professor Ring presented at Radla, we see that children have this really significant increase HSV and VZV and even CMV, and then this overall increase in risk of serious infections as well. And then you can see that they're opportunistic infections that we often classify as this eczema herpeticum. So as these microbes are interacting with our immune system, training our immune system, driving our immune responses, and essentially evolving with us as a human species, we see that the skin itself is a really complex immune organ. And not to be underestimated, the keratinocytes have their own vast capacity to respond as immune cells. They produce antimicrobial peptides, and that, along with the defects in the antimicrobial peptides, along with the skin barrier, can play a large role in driving this positive feedback loop in the disease, driving these innate alarm signals, we call them, like TSLP, and initiating the Th2 response. We know that a lot of these natural skin immune factors, the antimicrobial peptides, we often call them defensins, there's the cathelicidins, are defective in atopic dermatitis, as we've seen. We know that as well, recent studies have shown that in eczema herpeticum, there may be a lack of plasmacytoid dendritic cells, so specific defects associated with some patients and maybe in certain ethnic differences having more susceptibility to those defects in fighting off these viral infections. We know that toll-like receptors and other pattern recognition receptors play an enormous role here. And we know that these cells and how they're producing their antiviral and antibacterial responses really have a very complex molecular mechanism that is still at this time being elucidated. So understanding how these resident dendritic cells interact with these pathogen peptides and pathogen associated patterns is something that we're going to be following very closely over the coming years. With respect to eczema herpeticum, it's something that we really want to be very careful with because it can be a very serious complication of atopic dermatitis. And so you follow here some of these guidelines for managing atopic dermatitis complicated with eczema herpeticum. And you can see here that oftentimes not just the antiviral, but also concomitant systemic therapies with antibiotics may be considered. So we have staph, we have eczema herpeticum, not to forget molluscum contagiosum, also malassezia. So we have these very common infections that we're seeing on the surface of the skin, complicating our management of our patients on a day-to-day basis. And then we have the whole microbiome. So normal skin and this complex ecosystem, how it is balanced in health and disease, and how we're learning about that over the years. We know that we are filled with these microorganisms. We know that they play an important role in our good health as well as our bad health. And we know that our traditional means of controlling these microbes, especially the pathogenic ones, are not that effective in skin, knowing that skin is really populated very deeply with these commensal species. And so eradicating the microbe from the surface of the skin is really not as simple as it seems. This is a famous slide by Dr. Kong, who I'm sure you've seen before. But just to come back to this as a central, really landmark discovery in understanding this disease and understanding that controls have more diversity and that in disease we have this pink Staph aureus starting to overtake everything. So how does this all come together? And don't forget scabies. This is my last little plug for infections. So we know that all of these infections and these sort of surface ecosystem factors in the disease are playing an important role in how we manage. But how do you actually treat these patients if they do have a colonization or if they do have an infection? And how do you manage their infectious risk when you're giving them and changing their immune systems with your medications? So where are we now with the approach to management? We've certainly come a long way. You can see here recent guidelines from the European Eurogiderm on treatments with these antivirals, antibacterials, and even antifungals. So really suggesting treatment with topical antiseptics, including these bleach baths, which we'll come back to. Using short courses of systemic antibiotics only when there are signs of extensive clinical superinfected lesions, so not treating the routine surface colonization, supercolonization, or surface infection with Staph aureus. And really cautioning against the use of long-term topical antibiotics because there's a high risk of and prevalence of antimicrobial resistance with these fusidin and mupirocin treatments that we use frequently. And when you do have the topical anti-inflammatory treatments, the topical corticosteroids should really be continued while you have that infection, because we know that sealing the barrier is something that can promote the clearance of the staph. With respect to antiviral treatments, we know that treating eczema without delay is very important if you see this condition. And of course, performing vaccinations in line with your local guidelines. Often in the head and neck variant of atopic dermatitis, we're now promoting the use of antifungal treatments, knowing that malassezia, a yeast on the head and neck area, can promote disease in these areas. And this is very recent work done by Linda Schneider and her colleague Derek Chu et al., looking again at this age-old story of the bleach baths. So I think that it's really interesting to see where we're coming back to with respect to these preventive mechanisms we talk about a lot, whether or not to use emollients, how to talk about emollients. And I think that this is a really nice recent review of all of the literature that it does show us that there is evidence to support bleach baths still, 2 or 3 times a week. And it probably improves the severity, maybe not enough, but it can play a role. And certainly it has very little risk. So now we're managing patients with more than just wet wraps. And we're able to manage these patients with very complex immunomodulating therapies that come with their own risks and which will change our immune systems over the coming years as we are all exposed to these capacities to actually adapt our immune systems to the environmental triggers and microbes that we see. So what do we think about these and infections? We like to classify these medications as, as medications that help atopy in general, but we can see and learn very much from the medications. There's specificity in helping eczema versus asthma, and understanding now more and more why certain medications do work for eczema and don't work for asthma, or work for asthma and don't work for eczema. Understanding that the Th2 responses are complex, not all Th2 cells are the same, and that we're going to learn more and more about how we can really refine our treatment options. So when we come to something like this, with our eczema herpeticum, in all of its clinical manifestations, it is very important to recognize. So I've put up a lot of photos here. We know that these patients do have this increased risk of HSV, but really only a minority of our patients do develop the herpeticum. We worry about it because it can be life-threatening. And we've seen that, in studies, clinical trials with dupilumab, they do show a slightly increased risk of HSV infections, but these are not serious. Interestingly, this biologic can actually decrease the risk of serious HSV infections. So that when you look at dupilumab versus placebo, this serious complication, eczema herpeticum, is reduced. Similar expectations for tralokinumab and lebrikizumab. In contrast, our JAK inhibitors do show increases in overall frequency of these infections versus placebo. And that being said, they're also not serious and probably should not modify treatment decisions. Consensus statements can be made that in patients with AD, the frequency of this HSV certainly can be modified by the treatments we're giving them, and that we should screen for the history and consider prophylaxis. So using our Valtrex as a rescue treatment is often really helpful when we're putting these patients on immunomodulating therapies. We know that AD patients have this increased risk of VZV. So what is the evidence of this in our pooled analyses of clinical trials? We know that zoster is reduced in patients treated with Dupi versus placebo. We know that as well, there's an overall, that VZV frequency of infection versus placebo is actually increased with JAK inhibitors, and there may be actually higher rates in Asian populations. When we look at head-to-head studies for the Dupi versus the JAK inhibitors, we can see that there's an increased frequency of that zoster with JAKs, but not with dupilumab. And zoster is not listed as an adverse effect in any of the clinical trial data for lebri or tralokinumab to date. So our patients should really be considered for vaccination prior to initiating these immunomodulating therapies, and adapting that to your local guidelines often takes into consideration also access to these vaccinations. It takes into consideration how quickly this medication is needed to induce a remission for your patients, and what to do if they're already on a medication and then they need to get vaccinated. We're still learning about how to adjust our immune responses to optimize vaccine responses and vice versa. With respect to herpes zoster, overall we can say that patients should be considered for vaccination as per local guidelines, as we just said. And then when we look at, these are, now we've gone through the common infections. When we think about the rarer things, so HPV, reactivation, these kinds of things, we know that HPV has really gotten has been flagged because of these other biologics, okay, so anti-TNFs, B-cell therapies. So what is the evidence for this with the current therapies that we're using for atopic dermatitis? Well, we know there's very limited data. Okay, so these are patients who are excluded from trials. So we do have a prospective cohort with DUP where we have 5 patients who did not receive HPV therapy and they didn't have any clinical significant elevations. So we may postulate that the biologics that we have for eczema right now are theoretically safe, but we're basing that on an understanding of the fact that antiviral responses are generally Th1 responses, and when we're blocking a Th2, we're not necessarily affecting that. But we're making these decisions based on very, very limited evidence, and it's a lot of postulation and theorizing so far. So overall, when you're thinking about putting these patients on systemics, doing the workup, making sure to screen for these underlying infections, and taking a look at their vaccinations is really important. If you can't get access for concomitant therapy to HPV, though, you may consider yes. Relative to other conventional immunomodulating immunosuppressive therapies, the biologics are going to be a good choice. What about TB? So we know that this is sort of similar to the HPV. We know that there's an increased risk with traditional immunosuppression. We know that the biologics we have currently for atopic dermatitis with their mechanism of action blocking the Th2 cytokines do not require screening for TB. We know it's the same principle that Th1 as a protective response, we don't necessarily affect that with our biologics, but again, we have limited evidence to suggest what to do here. So overall, we can just make sure that we consider very carefully the fact that latent TB, you'd want to be careful with your profound or broad-acting immunosuppressives. What about with pre-existing immune conditions? We have some limited data to suggest that dupilumab is unlikely to increase the risks of those with pre-existing immune disorders, for example, patients with HIV or organ transplant recipients. A special topic of COVID and atopic dermatitis. So this is something that is, it's still evolving. Obviously, we've now seen that over time. I think we're all comfortable now with continuing dupilumab in patients who have mild cases of COVID. And we don't think that dupilumab is going to affect that vaccine efficacy for COVID-19. And it's the same principle for the difference in the Th1 versus Th2 response. So the International Eczema Council and the ATVAD have recommended that DUPI do be continued. And the evidence for that is very interestingly also including some trends that we've seen in hospitalizations that may actually be decreased for patients on dupilumab. So vaccinations, so there's safety. We certainly have data now for safety and efficacy of non-live vaccinations with patients on this medication. And we know that that's a very important consideration that needs to be made in each individual case a bit differently. And this is the data that had shown that overall dupilumab may be associated with reduced risk of serious or severe infections and non-herpetic skin infections. And this is very interesting because, from an infectious disease perspective, is this considered to be a new form of an antibiotic therapy in the sense that we can now seal off the skin, reduce the immune responses that are pathogenic, and actually lead to clearance of these bacteria? And it's a very interesting thought to bring forward as we're learning about how the immune response affects these microbes and vice versa. So this is also serious and severe infections showing that decrease with the monotherapy studies and the studies with concomitant topical corticosteroids. And we actually have a nice set of recommendations from IEC members who ranked their preferred systemic treatments for the treatment of adults with AD in special patient populations, and particularly those who have HIV, for example, or chronic Hep B. This was done in 2020, so a while back before we really had all of these other options. But certainly there's a preference to use the targeted therapeutics, the biologics in particular, in these patients with latent infections. Now we know we have also recommendations, given that we have the ability to treat these patients more aggressively. We also have recommendations that we should be targeting treatments to be almost clear and easy less than 7, optimizing that treatment response based on your patients and their patient-reported satisfaction and reported outcomes. But interestingly, we know that we have even more effective therapies now if we want to look at EZ90 or EZ100 treatment. And we are having patients with these head and neck dermatitis, partial responders. We are using these JAK inhibitors. We know that these medications come with different safety considerations. And so when we look at the safety, what are we really seeing? We see that there's nasopharyngitis is not really touched, but oral herpes we can see does increase. And then we can see here that zoster, this specific signal for these herpes viridis. And we don't see that much of a difference between abro and upa so far. So coming down to the sort of very exciting world of the yin and yang of Staph aureus and AD, this is probably sufficient material in here to have a version 2 or a part 2 of this talk, because there's just so much active research. Every day there's new data and discoveries that are contributing to our understanding of how this one particular microbe and this disease interact. We know that early life infections precede the development of atopic dermatitis in infancy. We know that atopic dermatitis endotypes can be influenced by staph. We know that the staph enterotoxin beta in particular is strongly associated with more severe AD. As we said, we know families share that skin microbiota. We know that staph impairs human immunity in order to promote its own survival, and that protection against staph infection requires innate signaling and, interestingly, these Th17 cells that we were talking about with Amy just now. So we know that certain strains are more adept at driving AD, and it's a really very active area of research and debate now that we can do whole genome sequencing and align these strains using whole genome multilocus sequence typing and get into the metabolic genes and the metabolic adaptations of these bacteria, and to compare them with our own host metabolism. So this is where we think about these microbes as potentially being that trigger. We know that the anatomy of our normal cutaneous immune response is still something that we are peeling layers of understanding away at now, and that overall, one of the great mysteries, at least to me, is that we have such a high burden of staph on the skin, but we're missing the neutrophil, which is essential to clear this bacteria from the skin, which is completely tied to Th17 responses, and which seems to be missing in this disease, despite the fact that staph is so prominent. We talked about the armamentarium that this particular virulent pathogen has in its back pocket, ready to cause a lot of inflammation. But we also know we know that it can drive inflammation in many different ways. But there's a Dr. Jekyll and Mr. Hyde situation here, because we know that although it's a virulent pathogen, and that lots of beautiful work done over the years that I feel terrible just skipping over, like Donald Young, doing so much work to show that inflammatory response. And even ourselves, we know that SEB in our group, we can see very clearly that you drop a little bit of the super antigen together with the alarmin TSLP from skin, and you very readily can generate Th2 responses in vitro that mimic the pathobiology that you see in disease. You can mimic TARC, you can generate these biomarkers. So we know that they have an important role to play, stimulatory, superantigens, generating T cell proliferation. But we also know that there's this missing bit of our immune system, which is trying to generate responses to extracellular parasites, which is not generating responses to intracellular organisms, and we know that staph in skin is living intracellularly. And so we have these missing bits of immunity that we're still trying to figure out in our atopic dermatitis skin. We also know now that the metabolic adaptations, as we said before, are very complex and are still being elucidated with very beautiful studies now. And it's very interesting to reflect on the fact that despite decades of global intensive research, we still have not been able to discover or to find a way to develop immune responses, vaccines against this important pathogen because of its capacity to manipulate our immune systems. And I will stop there because there is a part 2, but I would say what you can find within the International Eczema Council on their website with their enduring materials is really rich in information. There's a lot of very interesting work being done that I would love to get into now. But given that we've already covered quite a lot, we'd love to talk more about where we can go. Let's go back to the conclusions for this talk. AD patients have increased infection risks at baseline. Staph dominates skin surface ecosystems. Reduced diversity plays a role in this disease. Within that, we know that the infections, the infection risks, the microbial colonization of our skin really are important considerations when we're managing our patients, and that our targeted therapeutics can really modulate these risks, for the better or for the worse. We know that staph and AD are very strongly associated, that it can be a highly virulent or quiescent and pathobiont. In our human evolution, staph has a really special role. There are plausible pathogenic mechanisms there, where it may be inducing the skin damage, the inflammation, the disease activity, and flares, and that there's lots of research ongoing, which I'll be really happy to be involved in and to follow along over the course of the years. So I just wanted to say thank you. And to also note that there are International Eczema Council fellowships now, even extending to Canada. So if any of the fellows are interested in applying, they can be found at the website for IEC. Thank you very much.
Thank you, Dr. Jack. Well, we are running a bit behind, but there is a light at the end of that tunnel in that we have built in a very long time at the end for a panel discussion. So if we have to eat into that a little bit and people can hang around longer if they have other questions answered at the time. I think everyone does need to stretch their legs. So would everybody be okay with a 10-minute instead of 20-minute little break? Okay, with that said, we will be back, what time is it now? Whoops. Back at 3:43. 3:45, we'll just round it out to. So you all already had the chance to meet Dr. Robert Bissonnette. I get to formally introduce him now. Dr. Bissonnette is board certified in dermatology, and he is the president and founder of Innovaderm Research. He has published over 230 articles and book chapters, and gives various lectures on all aspects of dermatology at national and international meetings. And he is going to be speaking to us on a very important topic for all of us, emerging topical therapies.
Okay, very good. So, as we're a little bit behind, I'll jump into the subject immediately. I'm very pleased to be able to give this talk about emerging topical therapies in atopic dermatitis. This talk will be very practical. I will be talking about drugs that are on the market now, some approved for AD, some that are not approved for AD, but still on the market that you could use when you go back to your practice early next week. Right, so good. So these are my conflicts of interest. All the drugs I'll be talking about, I have conflicts. I don't have shares. However, I served as an investigator or as a consultant, or I receive an area from those companies. All right, so these are the ones I'll be talking about. I'll be talking a little bit about crisaborole, and I'll be talking about ruxolitinib. These two drugs are approved for the treatment of AD. They're available in the US. I'll be talking about roflumilast and tapinarof, which are available topically in the US to treat psoriasis, but they're not yet approved for atopic dermatitis. So crisaborole, some of you might say, well, this is not an emerging therapy. It's been on the market now for a little while. And you're right. You're absolutely right. It's a PDE4 inhibitor. As you see on this slide, it inhibits and decreases a number of cytokinin pathways, including Th2. I'll be talking about two studies with crisaborole that I think are very interesting. This one came out a few years ago and looked at what happens if you apply crisaborole first and then a moisturizer versus if you apply the moisturizer and crisaborole after. So what they did is they worked with abdominal skin ex vivo, and they did those studies. What you see in blue is penetration of crisaborole if it's applied alone. What you see in light gray is penetration of crisaborole if you apply the moisturizer and you apply crisaborole immediately after. So you have a reduction of about 75%. This is really important for a drug with moderate efficacy. What you see in yellow, which is also good, is if you apply crisaborole first, you wait 15 minutes, and then you apply your moisturizer. And in between, it's crisaborole, you don't wait, and you apply your moisturizer. Now, what's the take-home message? We need to ask our patients what they do. So ideally, the best thing to do is to ask them, because they will remember more than if you tell them. Some patients do apply, they don't know. They apply the moisturizer first and then they apply the product later. This is probably important for drugs that have low to moderate efficacy, like the TCIs, crisaborole, or our low potency TCS. Another study I want to share the data with you with crisaborole is a study we conducted, so it was a single center study published in 2019, which looked at recruiting patients with AD and applying crisaborole on site twice a day for 2 weeks at 3 milligrams per square centimeter. So this was applied by nurses, was weighted every time. It was perfectly 3, not 2.8 and not 3.2, so totally artificial. In clinical trials, usually based on what I've seen, people usually put between 1 to 2 milligrams, and some put even less than 0.5 milligrams per square centimeters. What we've seen is a very nice decrease on the side treated with crisaborole in terms of pruritus, statistically significant with 40 patients as early as 24 hours, and also up to 60 patients, 60% of patients who would reach IgA 0/1 with a 2-grade decrease after 2 weeks as compared to vehicle. On the right, I put the phase 3 study where at 2 weeks, the proportion of patients with IgA 0/1 was around a little less than 30. You can't really compare because these are not the same studies, but used this way, it seems to be much more efficacious. In my practice, based on this, I started to change the way I tell patients how to use the drug. What I tell patients to whom I prescribe crisaborole is I tell them, use a thick layer. I'll tell them the pharmacist will tell you to use a thin layer, but don't listen. Use a thick layer. And there are studies done with crisaborole showing that penetration is not very high in maximal use studies. So take-home message, consider something that is off-label, because the label says thin layer. Consider telling your patients to use a thick layer, specifically if they treat small areas, specifically if they treat hands, for example. In some patients with chronic hand eczema, topical crisaborole is good, works well, but they have to use a thick layer. This has been a change in my practice with crisaborole. I see more efficacious data with that. Ruxolitinib, approved in the US for AD. It's available. It's something that you may have started to use. Very impressive drug in terms of efficacy. In all the drugs that have been able to work, the topical drugs in atopic dermatitis, this is probably the most efficacious one in my experience. Very impressive. JAK inhibitor, JAK2, JAK3, TYK2. Results from the phase 3 studies, you probably have seen this at meetings, sales rep have probably shown this to you. In terms of patients that are clear, almost clear, with a 2-grade decrease, with the concentration that is approved, which are the bars in blue, you have about 52 to 54% of patients who will clear, almost clear, as compared to 7 or 15 with the vehicle. One thing you need to be careful when you compare across studies with topical drugs, and it's not like with the systemic drugs. With the systemic drugs, Dr. Simpson will show us most companies are conducting the studies roughly in a similar population, not identical, but fairly similar in terms of BSA and EASI and severity. But it's not the case for the topicals. So some of the topicals were studied in patients up to 20%, like ruxolitinib. Other topicals were studied in patients with BSAs that are higher, so the severity varies. When the severity is lower in terms of BSA, usually you see a delta that is a little bit higher. Super efficacious on pruritus, being a JAK. From an adverse event perspective, Nothing really stands out in terms of adverse event for the most frequent adverse event observed. And we see a nice decrease in adverse events with an increase in the concentration of the product. And this is nice in atopic dermatitis because it's expected of a drug that you would consider safe, because patients on vehicle, they tend to have atopic dermatitis adverse events. Now, the issue with ruxolitinib is that it does penetrate the skin. If you use ruxolitinib on a large surface area, you can get levels that are significant. In this study that we published last year, we looked at treating patients with 25% BSA or more. Now, the label is up to 20%. If you're using this on patients that have more than 20%, you're off-label. So we treated patients for 1 month, BID, on the surface area that was affected by atopic dermatitis at baseline. After a month, we told patients only use it on residual lesions. What we've seen on the right, you see the level, the systemic levels of ruxolitinib in blue, significantly lower than if you would take oral ruxolitinib at 15 milligrams BID. However, we had 2 patients with very large BSA, 145 and 190, that had higher levels that were in the range of treating people with systemic ruxolitinib. The concentrations went down over time. Does show that well here because it's a log scale. So one thing that was really impressive in this study was the fact that after a month, about 60% of patients were clear, almost clear. And then if you ask them to only apply the product on lesions for an additional month, you increase this to 80%, suggesting that it's possible after a month, if you treat patients with large BSAs, to be within the label and use it on less than 20% and control them. Take-home message. So the label is up to 20%. You can get penetration if you treat patients with a higher BSA. You need to tell your patients to use a thin layer with this product. You don't need a thick layer. First, it penetrates. Second, the efficacy is so high that you don't need to put a lot. You can consider treating patients with a BSA that is higher than 20, and this is off-label. There would be 2 ways of doing this. One would be to see your patient and say, okay, start by this region of your body, less than 20%. Come and see me. If it goes well, then we treat another region. Another possibility might be to start treating somebody with higher than 20, seeing them after a month, and if they're down to less than 20, then you can continue. If you treat large BSAs with this drug, my suggestion would be to screen, monitor, and counsel as if you would be using a systemic JAK. You need to remember that this drug has a black box warning for JAK inhibitors. Roflumilast. So I'll be talking now about roflumilast and about tapinarof. I'll look at my time. I'm good. 10 minutes. So one of the issues here is that when you talk, you don't see your time. You need to move. So for the presenters, move a little bit. So roflumilast and tapinarof, unfortunately, we don't yet have all the phase 3 data available. We have some. So roflumilast is a PDE4 inhibitor. There's a lot of research activity right now. In order to be able to develop a PDE4 inhibitor that would be as safe as what crucible has shown to be, but more efficacious. With crucible, we have 2 issues. We have burning and stinging, specifically on the face, and we have the fact that the efficacy is moderate. So there's a lot of interest in developing drugs that are more efficacious. This drug, as you know, is approved for the treatment of COPD. It's also approved at a concentration of 0.3, higher concentration, for the treatment of psoriasis in the US. So phase 3 data has not been presented at meetings yet. However, it's on the website of the company. And this is what I'll be sharing with you today. The phase 3 studies were conducted in patients 6 years old and older with a lower concentration of roflumilast as compared to what's on the market for psoriasis, so 0.15 versus vehicle. The primary endpoint was the usual IGA 0/1 with a 2-grade decrease, and these are the results. So 32% of patients in one study achieve IGA 0/1 versus 15, 29 versus 17. So nice results because the delta is 17% between active and vehicle for both studies. And the delta is higher than the delta that was observed for crisaborole. Now, we don't have a head-to-head comparator trial, but based on the higher delta, this could be a drug that is more efficacious. We don't have all the safety, we have no safety data in phase 3 presented yet for this drug, and we have very limited efficacy information. So if you want to try to use this in your patients, I think it's good to go back to the safety data that we have for psoriasis. It's approved for psoriasis, again, at a higher 0.3 concentration. So 2 things you should be aware of. In the psoriasis program, there was a proportion of patients who had diarrhea in the groups treated with roflumilast as compared to placebo, as well as a slightly higher concentration of headaches for one group as compared to vehicle. In dermatology, we have a PDE4 inhibitor, an oral drug called apremilast that we use in psoriasis, and we see the same thing. We see an increased risk of headaches and an increased risk of quote-unquote diarrhea, but it's mostly soft stools. So it's unknown if we will see this in atopic dermatitis because the concentration is lower. However, penetration might be higher because of the disrupted barrier. So take-home message, this is on the market, double the concentration that has been studied in AD. We don't have any safety data yet presented for phase 3 in AD, although the phase 2 looked good. Due to the higher frequency of diarrhea and headaches observed in the psoriasis program, I suggest using a thin layer, and you probably should restrict the use off-label again to patients with smaller BSAs until we have the safety data available. Last drug, tapinarof. Now I'm heavily biased with tapinarof. Again, I don't have any shares, but this is a Canadian discovery. It's a drug that was invented in British Columbia, or discovered in British Columbia, and I was privileged enough to be the first physician to try it on patients in 2007. I participated as an investigator in all the psoriasis trials and most of the atopic dermatitis trials, so I'm a little bit biased. It's a very specific, different, interesting, intriguing drug. It's an AHR agonist. So it's not a JAK, it's not a PDE4. It's an agonist of a transcription factor called AHR. AHR is a bit special in terms of transcription factor because its activity depends on its ligand. Depending on the ligand it binds to, then it will give rise to certain actions. A very elegant publication that is referenced in this review paper was done by the GSK STIFO investigators, and the main author is in the room today, in fact. Looking at what is the mechanism of this drug, it decreases cytokine production, specifically IL-17, so that's why it's efficacious for psoriasis, but it also increases barrier gene expression. It has an antioxidant effect for which we don't know exactly what is the translation in clinic. So in terms of development, this product is approved 1% once a day for the treatment of psoriasis. The pivotal phase 3 studies have been completed, have been completely enrolled. This was released by Dermavant about 10 days ago. So the results should be available in March or May. So we don't have phase 3 data available yet, and I'll show you phase 2 data. The phase 3 studies were conducted with the same formulation once a day at the same concentration. So phase 2 data published a few years ago in JAD. Amy Poller was the lead investigator in that study. What you see here in orange is you see, and I'll focus on week 8 because this is the primary endpoint in phase 3. So in orange, patients on vehicle, about 20% at IGA 0/1 at week 8, as compared to close to 50% with tapinarof once a day. And this was statistically significant. We're awaiting phase 3 data. If you want to use this in your practice, you should be aware that this drug induces some side effects, some systemic and some local, and I'll review these with you in a moment. This is safety data from the phase 2 atopic dermatitis study. There are 3 things that this drug can induce that you should be aware of. First is headaches, then folliculitis, then contact dermatitis. So headaches have been reported in all studies conducted with this drug, and always a little bit higher in the treatment groups as compared to the placebo groups. The quote-unquote tapinarof-induced headaches, typically they are seen the first day of treatment, they last a few days, and they go away. Rarely have I seen patients who would stop because of this, but it's possible. Folliculitis is another adverse event. In fact, it's a misnomer. You will see in publications the word folliculitis used, but these patients, they don't have folliculitis. They have an inflammatory follicular reaction, a papular reaction. Sometimes they have pustules, and often they don't have pustules. I personally cultured a number of those patients with pustules, and it was always negative. So this is not a staph infection. This is not infectious folliculitis. Contact dermatitis, now I'm switching to the psoriasis phase 3 program because contact dermatitis was not specifically mentioned in the phase 2 publication, but I've seen it in atopic dermatitis. So in the psoriasis program, about 5% of patients had contact dermatitis adverse event, as compared to 0 or 0.6 on vehicle. This is not irritant contact dermatitis. This is not allergic contact dermatitis. I'll show you a few photos. We recently published, if you're interested in tapinarof, we recently published a review paper in Journal of European Academy of Dermatology and Venereology on tapinarof, sharing our experience with the drug over 15 years. So this is the quote-unquote folliculitis that you see with tapinarof. The center photo is probably what you see on average with a few papules around plaques. On the left, you have a patient with a more widespread, quote-unquote, follicular reaction with many small lesions. I can't be convinced that I see a pustule on this one, but sometimes you do see clear pustules. Tapinarof-induced dermatitis on the left, this is a very nice example of a psoriasis plaque that cleared with some dermatitis at the border of the plaques. In both cases, what you need to do if you see this is patients have to stop applying drug, and then it goes away within usually a few weeks. 2 more slides and I'm done. This one is something I want to share with you because I was impressed when we conducted that study. So we did the maximum use study with tapinarof in patients with BSAs with the atopic dermatitis. We're back to AD. Patients with BSAs between 15 and 25. And we studied the 1% concentration that is on the market, but also double concentration, 2%. And at the 2%, we had 3 out of 5 participants. On the first day after the first application, they had headaches, diarrhea, nausea, vomiting. And we discontinued treatment with the 2%. This was not observed with the 1%, but again, it goes in the direction that with this drug, specifically in atopic dermatitis, in patients with larger BSAs, you can have some systemic adverse events like headaches. And last slide on tapinarof, and then my take-home message. What's really fascinating with this drug is that in psoriasis, it's not been studied in AD yet, but in psoriasis, you treat patients, you stop treating patients, and then many patients will stay in a quote-unquote remittive state for months before the disease comes back. So what you see on this slide is from the psoriasis program. You treat patients, those are completely clear, you stop treatment, and you wait until their PGA is back to 2. And when they're back to 2 in psoriasis, it usually means 1 squared centimeter or just a little bit of psoriasis. And it took 115 days. 32 seconds, I'm on time. So, take-home message with tapinarof, if you use it off-label for AD, thin layer. This is another thin layer drug, no thick layer. If you treat extensive disease, consider starting with a small body surface area at first to try to avoid headaches. If patients have follicular reactions or contact dermatitis, they just stop and they can reuse the drug. If they use less, if they use a thinner layer, usually often it does not come back. And that's about it. Thank you very much.
Thank you very much, Dr. Bissonnette. Okay, we just heard about emerging topical therapies, and now we're going to hear about emerging systemic therapies with Dr. Eric Simpson, and I'm very happy that he's here because a couple of days ago, we all got an email that coming from Oregon, he might not make it. And he was changing planes in Salt Lake City, and he was going to look into alternate travel plans and what were we going to do, and was someone else going to present the data, or what were we going to do? And I don't even know what happened, but he's here, so isn't that wonderful? Dr. Simpson heads the Department of Dermatology's Clinical Studies Unit at Oregon Health and Sciences University and practices medical dermatology with special interest in chronic inflammatory skin diseases and skin cancer. He's actively involved in clinical research looking into new approaches in chronic skin disease treatment and prevention. He has published over 260 scientific articles in several high-impact peer-reviewed journals. And again, he's going to be speaking to us on emerging systemic therapies, treatments.
Great, thank you so much. Okay, so I have 54 minutes, so this will be easy. I'm joking, Robert's panicking. All right, so first I'm just gonna apologize. For the last 20 years, I've been sending allergists all my patients with chronic urticaria. Super mean, even especially before OMA. But I think in response, you guys have been sending me all your severe eczemas. So yeah, so I got nodding heads. So now I want you to take them back, and I want you to feel like really confident about treating severe eczema. Okay, so we're gonna talk about systemic therapy. All right, so I do a lot of clinical studies and consult. I don't do any promotional speaking. And I don't know how to advance a slide. I think, yeah. So I'm from El Paso, not too far from here. Only about 11 hours west. Yeah, that sounds good. Thank you. Okay, so, and I have a mixed heritage of a Mexican and Texan, actually. So I'm a little bit ambivalent about the whole Alamo thing, but hope you got to, you're going to visit it and learn some history, some Texas history, and see the graveyard or the tombs. So I guess I'll just start with the graveyard of biologics. I'm going to throw a little bit of cold water on the personalized medicine approach, unfortunately. Okay, so this is just quickly, I just want to let you know that how much activity is going on, what's been happening the last few years. So, and then kind of we're narrowing this down as been like nicely outlined by Amy, by Emma, by everyone, that it's really type 2 disease most likely. So these are all phase 2 biologic studies. So all the alarmins and keratinocyte cytokines failed, IL-33 failed. I have no idea why TSLP failed, like several times, unfortunately. 17C, interferon 1 or IL-1 alpha, IL-5 failed, IL-17 failed. We've been a part of all of these as well, so it's been kind of like lots of failures. IL-22, Emma did say that there was a subset, kind of a post-hoc analysis. Real severe patients did do okay, but I think overall didn't do that great. Interferon gamma failed. Even in patients where like some of these cytokines are shown to be higher, like in Asian populations, the IL-17 approaches did not work. And then even the microbiome, I was super excited, NIAID technology, all the preclinicals look amazing, and like it just completely failed, looking at Roseomonas mucosa microbiome spraying on kids with eczema, unfortunately. Okay, so there we are. So we're kind of narrowing it down, co-stimulatory, type 2, maybe cell trafficking. So looking at, Robert talked to you a lot about that left side, right? So how do you know when you go to the right side? And how do you know which one to start? So this was a question I was getting really annoyed by many of you industry folks out there who said, how do you define moderate to severe? How do you define moderate? And I was like, why are you asking me that? I don't really do that in clinic. Actually, the way we do it in clinic is, how do we decide when we advance therapies to systemic therapies? And that's the most important question from my perspective. And so we asked this to the International Eczema Council, and it was a consensus that there is no one easy score, there is no one body surface area, there is no one PRO. It's really if you've used adequate topical therapy, so in some type of aggressive approach, either higher potency topical steroids or trying to incorporate non-steroidals, and you do all of that, and the patient is coming back like, doc, I can't wait 15 minutes to put my crisaborole on, or I can't reach my back with all these topicals you're giving me, and I have a 20-year disease. This is like impossible. Please help me. That's when you, as a doc, say, okay, let's upgrade, and that's when we move to systemic therapy. And that was basically, this is a global consensus from Asia, from Europe, from South America, and make sure that they don't have something else that you biopsy, as we heard earlier from Jonathan. That you've addressed, that does have an impact on their quality of life, I guess. And you can consider phototherapy as just inconvenient and about a 40% reduction in eczema. when you're thinking about moving and escalating therapy, think about the other burdens on them. So not just their quality of life, but think about burdens that you maybe don't think about too much, but like in your patients with skin of color, dyspigmentation, you want to treat their eczema aggressively so they're not left with all of these dark marks that there is almost as burdensome as sometimes as the itch or the hypo and depigmentation. Think about where the eczema is. Is it in the hands and feet? Is it on the face? And then, as Carolyn Jack so nicely pointed out, having eczema herpeticum or having recurrent staph infections is a reason to treat aggressively. And things like targeted type 2 blockade reduces skin infections, especially EH and staph. And then think about, if they're clear or they're doing well, but they're using like daily medium or high potency topical steroids, that's not okay. That's a toxic level of topical steroids, and you're going to get rosacea-like effects, you're going to get atrophy, you're going to get steroid withdrawal. Those are all additional burdens when you're going to be moving up. And then there is this concept that, why don't we move patients forward with systemic therapy? And it's like this concept that I just learned about at the EADV, the European Academy. This was presented by a derm group of this concept of therapeutic inertia. So we kind of have therapeutic inertia. We don't want to move forward. We kind of want to do the same thing that the last person did, just to see, well, maybe it's going to work in my hands. And that was the, let me just see you back. Let me do another topical steroid, but instead of triamcinolone, I'll do mometasone, or just like say some other steroid name. There's like 400 of them. They don't do any different. I mean, so don't be that person, and I'll just do my shame slide. Don't be that provider that just like chooses another topical steroid or gives like another boost of Kenalog or another oral prednisone taper, because you're going to be stuck in the same place, or they're going to go somewhere else and just get the same thing over and over and over again. So I kind of have to shame my dermatology colleagues, so hopefully I don't have to do that with you guys. And it's not your agenda is not to make sure they get on systemic, right? Your agenda is like to give them the options and let them decide, because there's all these different options here, right? This is how I think about it in these buckets. And you try to use this shared decision-making process when you're thinking about all these different therapies. This is a decision aid that will be, so this is the L1 decision-making kind of like. Give them all the options, empower your patient, make sure it's suitable for them. So they're not making the complete decision on their own, but you're just empowering them and directing them, but really they have to be the key decision maker. And so I have some patients, I spell it all out and they say, no, I'm gonna wait for another 3 months. I'm gonna go do my gluten-free diet and I'm like, oh, that's great. I'll see you, no judgment. We'll talk about it all again in 3 months. And so you can use things like this. We'll be publishing this soon. Decision aid, just it kind of puts it in somewhat patient-friendly language of the different options, because there really is we have no data to tell us the algorithm. Like, it's not like high blood pressure and start with hydrochlorothiazide, or I'm sure you have, and your nice asthma algorithms. We don't have that. We just don't have the data to support that. So I can't tell you must start with methotrexate. It's better for the patient if you start with a biologic. It's better for a patient to start with a JAK. We have none of those data. So it's really a shared decision-making. So here are all your options. So let's just go through these. So biologics, why would you choose a biologic as a patient or a provider? The advantages is, really you could use it in any patient, as was nicely spelled out earlier, all those different niche situations, Hep B, Hep C, HIV, and you need a long-term approach, which is pretty much like all the time. Disadvantages, as Amy was saying, needle-phobic patients, or if for some reason you only need a short-term solution. So let's talk about a quick update of dupilumab. It's been mentioned recently. So you're clearing about 25 to 38% of patients in the 16-week studies at basically every age group. I think it performs very similarly in every age group. There's some slight differences in numbers. If you look at placebo-corrected effect sizes, they're all actually really similar. And if you look at PROs and you look at easy percent reductions, they're all very similar. So you know this. You've been repped out, for the last couple of years. So I think you know that this drug works. I know allergists really like phenotyping, right? It's been really important for you for asthma, but there's no phenotypes in atopic dermatitis. We can make them up. We all have our own kind of head and neck, or staph colonized and not staph colonized, or high IgE, low IgE. There's no clinical relevance to any of these phenotypes that we've been talking about. At least I've not seen any data to support like a phenotype-driven therapeutic. So this is just one example. This is an Italian group who just kind of made up these phenotypes. which are reasonable just because they look different. And they basically all responded to type 2 blockade in a similar fashion. And then one more phenotype maybe that you could think about as allergists would be, this was looking at baseline TARC, right? So that's like a CCL17, kind of, are you a type 2 patient or not? And so low TARC is like a non-type 2 patient, but these are proportions of patients who are responding. And so in your low TARC patients, you're getting better responses with dupilumab than in your high TARC patients. So like it's better to be non-type 2 with dupilumab, and you do better. But I think the reason for this kind of confusing picture is that it's the high type 2 were the more severe patients. So really it just works. I don't care what type 2, not type 2, IgE, it works for all patients because in the skin it's a type 2 disease. And then we nicely heard from Emma that dupilumab, that blocks signaling of IL-4 and 13, improves the barrier function, as she showed, reduces all different types of inflammation, including type 1 and type 17. Staph reduction within, so this is an old study. We just finished some data with an NIH collaboration. In 3 days, your staph, this is no topical antibiotics, no topical steroids, nothing. In 3 days after your first injection of dupilumab, log-fold reductions in staph colonization. Like it's really incredible and confusing. And we looked at transcriptome at those time points, and we did not see an increase in antimicrobial peptides. So we did see some, we're going to be publishing this pretty soon in JACI, possibly neutrophil Th17 cells that may be responsible for this improvement, as was nicely hypothesized by Dr. Jack. And then the nice thing is that comorbidities. So if you have all these allergic comorbidities, of course, it's kind of nice to block type 2, including prurigo nodularis, a recent approval. All right, and then I threw this in also. You're going to love this, like massive reduction in IgE. And this is my colleagues from the Netherlands who followed Dupi patients for a couple years, 3 years, and saw IgE reductions like 80 to 90%. This is for peanut and hazelnut allergens. What's missing here, of course, is like clinical responses. Like, is this going to treat food allergy or not? I know it can enhance kind of oral immunotherapy, and they didn't really do they said, oh, there's anecdotal evidence in this group that they had fewer reaction to these things. But of course, no more data are needed here. And then I'm going to skip this one, other than to say T cell responses on Dupi. You have actually the same or better T cell responses, T cell interferon gamma responses to both vaccine and to previous infection with COVID. So not immunosuppressive, of course, if anything, potentially immuno-enhancing to COVID. But there are side effects of type 2 blockade in general. Of course, conjunctivitis, this new concept of facial redness, psoriasiform dermatitis maybe is pushing people to Th17, and arthritis. And there's some evidence out there that maybe there's an increased Th17 adverse events to dupilumab. Extremely rare and extremely complicated, and there's a lot of confounding issues with all of these AEs. For conjunctivitis, I just use my ophthalmology colleagues. They usually use topical steroids or topical nonsteroidals, and it's temporary. So just have an ophthalmologist at hand if you can. I know it's hard to get into anywhere, but try to have a colleague that you can always refer to. Happens in kids and adults. And it's not Th17 driven. Some people have thought, oh, these are like an ocular rosacea, but some tear fluid studies recently done by Netherlands colleagues did not see any increased IL-17 in tear fluids, and actually saw in more severe ocular disease from dupilumab that they had lower type 2 cytokines. So it's almost like you're not treating them aggressively enough. And then facial dermatitis, just one update on that. I mean, I see the majority time, and maybe people would argue with me, but the majority time this is a patient if you have a patient with severe facial disease, they get better on dupilumab. So that wouldn't be a reason not to use dupilumab. And then there's this rare subset who get new onset facial or worsening facial, and it's real heterogeneous. You have to just use your dermatology powers, because it's not just going to be the dupilumab, it's going to be contact dermatitis, it's going to be steroid withdrawal, it's going to be rosacea. So just don't chalk it up to this new facial dermatitis, because it's a lot of other things, including like this patient. This patient was clear on a JAK, doing great, and I said, so are you using any topicals? Well, I use a little Triamcinolone on my face. I said, okay, and he was totally clear. Well, I said, why don't you just stop the Triamcinolone? Let's just see what happens. Oh, I've never done that. Okay. And then he texted me this picture 2 weeks later, like pretty bad steroid withdrawal on a JAK inhibitor in one of our trials. Okay, moving on. Yeah. So we'll move to tralokinumab, IL-13 blockade only, not Dupi, which is 4 and 13. And it works very well against placebo, probably not as effective as dupilumab in terms of a percentage of patients who are clear, but gets better over time. And if you look at longer-term results, well, this is short-term results. Let me just show you this. So the red line is Dupi, and this is a network meta-analysis. It's really nice work. This is a live, you can find it online. Every new study that comes, it gets put into this network meta-analysis, but it just gives you an idea of like relative efficacy. So red line's Dupi, tralokinumab is a little bit to the left, which is like not quite as potent. And then you see the two that we're going to finish up on. The higher dose JAKs are more potent in skin clearance than dupilumab. That's the bottom line. I think that's like pretty much all you have to know. Tralokinumab does get better over time. That's the IL-13 blockade alone. And you get the benefits from IL-13 blockade that you do from Dupi in terms of reduced staph colonization, improvement of the barrier, improvement of diversity of the microbiome. Okay, so your biologics aren't working, or patients don't like them, or getting side effects. You know, do you have anywhere else to go? That's what's great about having JAK inhibitors. So the advantage about JAK inhibitors is that they're at the higher dose, they definitely appear more effective than dupilumab. If you need a quick response, if you hate taking shots, and you need to get deeper responses. So if you want, more people clear, the patient needs to be clear, and Dupi's not doing it, Tralo's not doing it, then JAKs could potentially do it. And there's a debate, should they be first line given that their theoretical safety baggage? So in general, they all improve itch rapidly. The efficacy and tolerability and safety is really dependent on dose. I think they're appropriate systemic therapy, potentially even first line, that's debatable, with a good shared decision-making process. So just think about these AEs when you go and start writing a JAK inhibitor for your atopics, okay? Headache, nausea, vomiting, they're common. They're usually not, they don't stop you from using the drug. Acne happens in both, a little bit more with UPA than Abro. They both block JAK1, so they're very similar molecules. It'll be up to you and how much you listen to representatives about like which one you're going to use first. And then herpes simplex, as Dr. Jack mentioned, JACK, and herpes zoster are both elevated with the use of these JAK inhibitors, so, no doubt. Low frequency, sorry, Jonathan just got that. The concerning things are serious infections, venous thrombosis, MACE, and malignancy, but it treats other comorbidities. Alopecia areata, that might be good. Vitiligo, facial dermatitis from Dupi, it could be good. So when not to use it? History of malignancy, family history of clotting, history of severe infection, severe renal liver disease, significant cardiovascular history. If you're going to be pregnant, are pregnant, or breastfeeding, think twice about at least the high dose with elderly, and then patients with a low tolerance for rare risks. So why do I say rare risk? Why does it have a black box warning? I'll just quickly show you the frequencies of events that got at the black box warning. This was a study of rheumatoid arthritis patients over 50 with one heart disease risk factor. They could also be on methotrexate and prednisone. And this 5-year study of tofacitinib failed on all safety signals. MACE events, that's cardiovascular, cancer, thrombosis, failed them all. And the reason was because the relative risk hit the threshold that the FDA was interested in. But when you think about it, and you look at the frequencies, just look at the top right. The frequencies of these events, this is after 5 years in this high-risk group with what would be considered a pan-JAK, an older JAK, in a high-risk group, including RA. Yes, the relative risks are higher, but look at the frequencies. They're like 1% after 5 years, 2% after 5 years, 4% versus 3% after 5 years. So yes, the relative risks are higher, but they're rare events in this population, in this like higher risk population. This is the atopic population, okay? These are events per 100 patient years. Serious infection, I'm not seeing a risk, an elevated risk compared to placebo. I could not find any population data, but I think you theoretically could have increased serious infection. VTE, venous thrombosis, abro, UPA, they're like pretty much at the moderate to severe AD population rate. And it's actually, if you remove the over 65, they're like way below it. Now, it doesn't protect you from VTE, so don't take that away. I think that's real. I mean, I think there is a risk. I just think it's low. Same thing with MACE. I mean, lower than the population of moderate to severe AD. I think the risk is there, but it's low. And this is after like a couple years of treatment in 2,000 patients. And then malignancy, same thing. Okay, so the rare risk, I'm not going to say no risk, but rare risk. So, don't freak about these drugs, and they're extremely helpful. So I frame the risk as like, this is the worst case scenario. I talk to my patients about these frequencies. In an atopic patient with a more targeted JAK, who have fewer comorbidities, I think they make a lot of sense, especially for your biologic failures. And what you get from it, how long have I been beeping? I'm almost done. What you get from it are really high rates of clearance. So 62, 52% IgA clear, almost clear at higher dose. Similar, a little bit lower with abrocitinib, but still really high efficacy rates. The indirect comparisons, including head-to-heads with high dose, show that it's at the high dose. What I've been saying is higher. It's better efficacy than dupilumab. Dupilumab kind of chugs along and starts slowly catching up, but they're very powerful therapies. And I'll just finish with this kind of practical consideration. So we talked about the history. You should be asking. There are some drug interactions, so just check those. You're going to have to check labs, immunosuppressive labs, at baseline, 1 month, and every 3 months about. You could get vaccinations up to date, and then birth control is needed. And as these start coming out, you're going to see rare side effects, like this is a psoriasis flare from a JAK inhibitor, unfortunately. And then there's new biologics coming, other anti-IL-13s coming with really nice results, as well as OX40 pathway. We've been talking about remission. We're going to get remission with tapinarof. Hopefully, maybe these OX40s are going to provide remission in the phase 2. They're showing some long-lasting results, some results close to Dupi. And then when you stop the drug, we're hoping that these OX40 ligand or OX40 blockers are going to provide some long-lasting results. So in summary, please avoid therapeutic inertia. I think dupilumab is still the gold standard. It's been out so long. It has really nice comorbidity results. Tralokinumab is a new, safe alternative. It looks like there may be less conjunctivitis and fewer rare SEs, so think about that. Oral JAK inhibitors are potent options, especially for biologic failures, but choose your patients carefully. And hopefully we're going to have some remittive therapy come someday. So thanks so much. Go do some good for your patients. I appreciate the invitation.
Thank you so much. That was a great talk, as they all have been. And now we're going to finish out the afternoon. We've been talking about all these great therapies, and now Dr. Agachi is going to be talking to us about how do we prevent atopic dermatitis from happening in the first place, prevention strategies for atopic dermatitis and the Atopic March. Dr. Agachi has the award of being the farthest traveler for this symposium today, coming to us all the way from Romania. She is a professor of allergy and clinical immunology at Transylvania University in Romania, past president of the European Academy of Allergy and Clinical Immunology, which we know as IEC. Her research in the field of allergy and asthma and clinical immunology focuses on asthma phenotypes and endotypes, immune modulation, immune tolerance. And she is editor of several books, deputy editor of allergy and associate editor of clinical and translational allergy, and a member of the JACI editorial board.
Good afternoon, and thank you so much for the kind invitation of being here. I'm an allergist. I'm happy to be here, and I'm very impressed of this meeting. And we will be very happy to host you in our IEC Congress if you are willing to join us. So these are my disclosures. None of them are relevant for the talk that I'm going to give today. So we are stepping into the prevention part. So we will discuss a little bit about the atopic march from epidemiology to mechanisms. Then looking at what could be the prevention targets, keeping the same discussion that we had all this afternoon, the inside out versus the outside in approach. Looking at a brief overview of the current approaches that are there for prevention, and of course looking at what the future holds on. So colleagues, this is the current view that we have, or we had, on the atopic march, with the food allergy and atopic dermatitis opening the gateway for asthma and allergic rhinitis. But understanding a little bit more on the mechanism, we have to change a little bit the perspective of what we call the atopic march, because we know that we have IG and non-IG mediated, at least in the food allergy world. And also we have other diseases that are coming into place, like, for example, eosinophilic esophagitis, and we have to continuously add to this in the epidemiology perspective that we provide. Now, also looking at the epidemiology, you can see here that actually very few people, very few children, like 3%, go on developing the classic atopic march that we are taught upon in the medical school. And the majority, for example, they just persist having eczema only, or they do not, they just go ahead and they clean out the atopic dermatitis and they do not develop any other allergic diseases. I think this is very important when a patient comes to you and he asks you, my child has atopic dermatitis, is he going to go into asthma or allergic rhinitis? And we have to have a clear answer to tell to that patient. And for that, I think that we have to look a little bit and discuss what are the mechanisms and understand a little bit better how this atopic march is going on. This is the evaluation of the risk of developing asthma in children with atopic dermatitis. And you can see that the severity of the atopic dermatitis is the least important. So this is not important, this is not something that you can use in explaining or predicting the development of an atopic march in your child. And the two most important things that come there are sensitization to food allergens, as it is expected to be, but also the parental history of asthma. So there is a combination between genetics and epigenetics that comes there. And the exposome will be very important, and I will come back to that. So, looking at this, what could be the intersection between being food allergic sensitized or sensitized to inhalant allergens or having the atopic background? And if you look at what is where the methylation marks are happening, they are happening mostly in the transcription factor binding motifs. That means that the epigenetics is continuously shaping the phenotype of the cells. And how does this happen? So, for example, looking at the T regulatory cells, which are very important in dampening the immune response. Why? This, I'm pretty sure that you are familiar with this cohort where they checked the difference between non-sensitized after 1 year, those who are sensitized but are tolerant, and those who are developing food clinical manifest food allergy. And the big difference comes in the presence of these T regulatory cells, which is increased more than in those who are non-sensitized. So they are very important. They are there. They have the sensitization, but it's kept under the control under these T regulatory cells. But these T regulatory cells are not stable. They always evolve, and this is what we call the plasticity of a cell. So its phenotype shifts continuously. How does it happen, for example, is again the outside in. So what comes from the exposome continuously shapes the immune response that we are having. And to the left, for example, you can see that if you have a good diet and you have a normal intestinal flora, then the T regulatory cell is under its regulatory phenotype and it dampens the immune response. If you have dysbiosis or a bad diet, then the barrier is compromised, and then the phenotype of the same T regulatory cells changes into a pro-inflammatory one, and then you have inflammation. And it's in one of the talks, I think it was from Professor Gutmann earlier today, we heard about this important role of epithelial-derived cytokines. And one of the most important is IL-33, because IL-33 is the one who will change the phenotype of the T regulatory cell, and instead of tolerance will promote the inflammation. There is always a continuation, crosstalk between genetic and other components of the exposome. For example, you know that there is a very interesting gene that predisposes to the impaired skin barrier and, of course, to the development of atopic dermatitis. But when we look how this genetic background, which clearly is related to the atopic dermatitis, is also allowing the development of the atopic march, it's not enough. So if you have this gene, but you are not allergic to food, then you are at no risk of developing asthma in the future. If you have this atopic dermatitis gene and you are sensitized to foods, as I have shown you in the beginning, that being an important risk factor, then you have increased risk of developing asthma. Same if you have this risk gene for atopic dermatitis and you are sensitized to aeroallergens. So two important things that you have to have in mind in calculating your risk score, as I will tell you more. Again, skin barrier is extremely important. We know that if you have, at least in the experimental model, in the animal model, if you have a filaggrin defective phenotype, then you have a spontaneous lung inflammation, both type 2 and non-type 2. It's not the same in humans, because when we looked at the epithelial barrier in humans who have asthma, we didn't find any filaggrin deficiency there, but there are other components of the innate immune response that might be important. Now, what could be the potential prevention targets? So, again, we have to look more into the exposome, I would say urgently. I felt it a little bit absent from the talk today. Everybody was talking about the outside, the inside out, a little bit less about the outside in. And colleagues, we are facing the climate change and the heat stress and a lot of things that are coming on our children very, very often now. So we have to look a little bit more into that target as well. But we also have to look at there have been a lot of discussion about the epithelial barrier, about restoring the skin microbiome, and of course, in the future, maybe look at in fixing the epigenetic abnormalities or the metabolic abnormalities that occur in this disease. I will not touch too much on these emollients because they were very nicely discussed, but just to show you that very few studies have looked at other comorbidities, like, for example, food allergy, and none of them is looking at the occurrence of allergic rhinitis and asthma. Maybe they are not long enough. I hope that they will have some follow-up observation in the future, but I think it will be very interesting to look at those as well. Now, the second, so one target is improving the skin barrier, then we can do immune modulation, and this has been repeated many times today, what dupilumab is accomplishing, just to show you that it has a systemic component. Dr. Goodman was mentioning this effect on atherosclerosis and cardiovascular disease signaling, but I think it will be very interesting to see if we fix the barrier defect in the skin with dupilumab. Are we fixing the barrier defect in the lung or in the nose? We don't know, and nobody has looked at that. So, giving the systemic effect of dupilumab. Another possibility to do immune modulation is to improve the gut microbiome, because we know that there is this nice crosstalk between the gut, the skin, and the lung. And we know that the good diet, for example, with short-chain fatty acids improves the normal flora, and it has a lot of regulatory effects generating both B and T regulatory cells. And when should this immune modulation occur? Of course, in the window of opportunity, as we have seen in the first year of, up until the first year of life. And there is one trial looking at this. In evaluating the impact of hypoallergenic milk products for children with cow's milk allergy in different combinations, one of them being with the addition of lactobacilli. And you can see here that the immune tolerance to cow's milk proteins is increasing. So from the mechanistic point of view, you achieve better immune tolerance if you add this probiotic in the preparation. But why I'm showing this is that because they specifically looked at the evolution of the atopic march, and they defined the main outcome of the intervention as the children with more than one atopic diseases at 3 years. And here, the association of the probiotic was clearly helping in achieving this, in preventing the development of the allergic march. And if you dissect the components of the main outcomes, it was they achieved prevention of asthma, rhinitis, and eczema as well. Now, to the last part. Because allergy is a typical One Health issue, being influenced by a lot of components of what we call the exposome. What can we do here? So, as you know, in Finland, they do have these nice programs of inducing immune tolerance, looking at the overall impact. So changing from what we call standard day care to a biodiversity intervention care with a lot of greenness and a lot of touch with the soil and more holistic way of living. And we do not have the results here yet, but I can show you another study that was really a nice evaluation of this type of intervention. So if you have more greenness and more species richness index in your daily life, then you have decreased risk of allergy and asthma, and rhinitis in the future. However, I still think that we need to personalize, because in this family, what will work as prevention will for sure not be the same as for this type of patients that we have. And for that, we need to understand the impact of the and we have to apply the science of the evaluation of the exposome for the atopic march. Why? Because this exposomic approach is very applicable for the environmental causes of chronic disease, and allergy is an environmental-driven disease. It offers you a risk profile instead of a single predictor, and it allows you a concomitant access to biological data, to exposure data, and to health outcomes, and that allows you to evaluate the biological plausibility of their hypothesis. It works through biomarkers, so we have 3 types of biomarkers: biomarkers of exposure, of susceptibility, and of response to disease. And I will show you some potential biomarkers that we are looking at now for the atopic march, combining the skin to gut to airways crosstalk. And one of them is the free mitochondrial DNA, which is released after tissue damage, which activates the STING pathway, and also the pathway of succinate, Taft cells, and activating the T2 pathway. The second one is looking at, for example, the lesional and the non-lesional transepithelial water loss and filaggrin expression. This is in white children, and also looking for specific exposome biomarkers in black children, because it has been shown that they are not the same. So it's a race-related effect there. And third is looking at these interesting receptors, Mars-related G-coupled receptors in the GI and the respiratory tract, because they are alert signals for following damaging signals which come from the exposome. For that we use, because we have a lot of data and we are working with big data here, collecting everything that is in the exposome, we combine using this multidimensional endotyping approach and building clusters, and then we have to show their clinical relevance, we have to show their cluster stability and reproducibility in different populations, because as I have shown you is very different, and then responsiveness to intervention. Because we want to achieve this as validated research tool issues, but also do some drug development program. And concluding remarks, I hope that I kept with time. We need a better understanding of the mechanisms of the atopic march, as I have shown you. We need, however, I still think that at least as an allergist, we need an endotype-driven targeted prevention in the personalized medicine approach. We have both the outside, the exposome, and the inside, the barrier and the immune dysregulation should be targeted if we want to achieve. I don't think that one part is more important than the other. And we have at least 3 key interventions that we might look. One is the microbiome, the second is the epithelial barrier, and third is the diet as key resilience pillars that should be further explored. With that, I would like to invite you to visit our T2 disease module. The atopic dermatitis was developed in collaboration with Professor Gutmann. Thank you so much for the invitation today.
We still had 4 minutes to spare. Great job. I'd like all the faculty to make their way up here for an abbreviated panel discussion. Every symposium I've ever been involved in, usually the panel discussion only lasts about 10 minutes. Thank you all for your patience and attendance today, and we'll just abbreviate it, and I think everyone will get a lot out of that, anybody that's able to stay. And I'm assuming that the speakers will be available briefly afterwards if you don't get your questions answered. Okay, does anybody have any questions for our esteemed faculty? If you do, please go to the mic, because again, this is a recorded session.
And I'm going to start asking questions if...
I got some too.
Could I ask one? Amy, do you think lipid changes are primary or secondary in atopic dermatitis? Because I know my answer on staph, but what do you think about lipids?
You know, I think that's so hard. It goes back to the chicken and the egg story that we've been talking about for years. And I think that the real answer is that there's such heterogeneity that there isn't one answer. However,
right.
I do think,
try.
Yeah, but I do think that they're central to it. And I think if we discover the evidence that we can predict in advance, at least in part for lipids, and there is a sizable portion that is. You know, the demonstration of the increases in TSLP or IL-13 or TARC, especially fairly early on at least, certainly suggests that inflammation is part of that. But I think you have to go back maybe even earlier to ask that question than 2 months.
I'm sorry to jump in there, Chair.
No, I'm glad you have a good question to ask. I have a question actually for Dr. Silverberg. It was way toward the end of your talk and may or may not be clinically important. No, I think it is clinically important. But this comes up a lot for us as allergists with regard to drug allergy, eczematous eruptions. And I know that I've gotten one too many consults at the hospital for patients that are believed to be having a reaction to hydrochlorothiazide or any of the diuretics in that family. And there's this conception out there that there's a strong cross-reactivity between sulfa drugs, and we just don't see that in the allergy community. But I wanted to hear what you had to say to speak to that. Is that connection or lack of connection? Has anybody else had these kinds of consults?
Yeah, so from the eczematous drug eruption perspective, I don't think there's a whole lot you have to worry about. You know, there's still a broader discussion from drug eruptions, and actually with contact dermatitis, like for patients who have very strong positive reactions to paraphenylenediamine, do have reasonably high rates of cross-reaction with sulfa drugs. And we've actually had multiple patients who've had problems with I'll just use brand name only because it's the one we use, Bactrim as an oral antibiotic, who've been hospitalized previously. And then they're coming in unrelated for some contact derm issue, and we find strong positives for PPD. So if they're, in the literature shows if they have 3+ reactions there, then you really should worry about the cross reactions. If they have 1+ reactions to PPD, you don't worry so much. So it depends on the strength and how bad. But if they have had severe reactions, I do worry about it, but not in the eczematous realm. That would be more of, you know, full-blown systemic reactions, just, you know, your typical drug eruptions that land them in the hospital.
Okay, so that's a cross-reactivity between PPD dye and Bactrim
well, it's the
algae.
whole. So it's PPD. There's a mnemonic we use: PABA and PACE. So it's parabens, paraminobenzoic acid, hydrochlorothiazide, the thiazide diuretics, aniline dyes, azo dyes, ester anesthetics, PPD itself, and then the sulfonamides or sulfa drugs. So it's and they don't all cross-react to everything, right? So that adds to a certain degree of complexity. But when we're trying to sort of be proactive about it, if I have someone who's a 3+ reaction to PPD, I would probably steer them away from hydrochlorothiazide down the road. And I kind of tell them, like, one day you're going to be older, you're probably going to be on blood pressure medication. Keep this in your mind because we don't want you to end up in the hospital with a drug reaction. But there's no real way to predict that other than knowing the probabilities from the literature.
Right. Well, we as allergists try to spend as much time as possible trying to delabel our patients of drug allergies, so it makes it a little difficult. Here we have a question. Great.
From Columbus, Ohio. 2 questions. One for Dr. Simpson. Most of us who are allergists are a little bit more leery about the JAK inhibitors. We're very comfortable with dupilumab, obviously. If they come out in different orders, one has been approved before. I mean, if you think about it, it seems like an oral drug is a lot better than a drug you've got to inject. And as Amy talked about, we've got lots of patients who don't like getting injected, every couple weeks. So just thought about that.
Yeah, sure. Before dupilumab, we were using cyclosporin, so I think I could safely say it's safer than cyclosporin. And so, yeah, if it would have come out first, maybe it would have been placed in a different, in the FDA's mind. They have some kind of interesting indirect language saying they should be used after other systemic agents, but they don't necessarily clarify that should be a biologic. So I think we could have a debate whether, I think there are people on this stage who have used them as first line. And so I think a discussion with your patient, and then because of that language in the package insert, I'd recommend if you do use it first line, to just document why.
Can you, Roger, let me just ask a quick question while you're on that. Can you just talk about access of JAK inhibitors as first line versus not? Because I think that's also quite relevant, if that's okay. Sorry to interrupt.
Yeah, I can barely get dupilumab first line. So it's going to be so heterogeneous in terms of where you live in the country and what type of insurance you have. So
our payer mix also is very different in DC than it used to be when it was in Chicago. Actually getting it first line is really no harder than just getting it for the JAKs, because there's no way any patient could ever afford any of these medicines without the patient assistance programs. Once they're enrolled in the patient assistance programs, many of them are just giving the drug away for free until we can somehow convince the insurance to eventually give. So most of the patient assistance programs have an allowance for using it first line if it's the right choice. So I don't see access as the bigger problem first line. It's just a global issue, as Eric is mentioning.
And my second question is that, Jack, since I'm an old allergist now, and staff has been a big deal with atopic dermatitis for 40 years with us. And our big focus 40 years ago was discovering that we had, IgE against staph. That was the big thing. I'm curious where you guys stand on that now. About that. Is it staph that we have an immunologic reaction? Is it those people who develop an allergy to staph who really have the problem?
Yeah, absolutely. I think there's a lot of potential mechanisms there that are really interesting to explore. I think that there have been studies to support the fact that staph may act as an adjuvant in developing allergies, and then I think that the concept that you're developing almost an allergic reaction to this species, perhaps for its own survival benefit, with an evolution with us, is very interesting to explore. But there's certainly a lot of counter-regulatory mechanisms, and the staph can either be a very virulent pathogen and become invasive, or, as we've seen, it can actually turn all of that off by adapting its quorum sensing and essentially turn down this virulence so it lives in a very quiescent state with us. So I think that this will be, the range of immune reactions to that staph organism are still being explored.
Does anybody else have any questions? Or yes, you do.
Actually, one of the questions I had was with respect to oral immunotherapies and the development of eczematous dermatitis. Given that you're using essentially a single antigen, you're developing a clonal response. My understanding is that you do have eczematous adverse effects to the oral immunotherapies. And I was curious to know if anyone had looked into that clonal response versus the polyclonal response we see in atopic dermatitis.
I see it all the time in my practice, patients that are started on oral immunotherapy and their eczema gets worse, and we have to slow them down, really slow them down sometimes. I don't know about the rest of you. I know most of you are dermatologists, but yes, we see it. I don't know I mean, we can guess the mechanism, but it's always a tough decision to make when you're treating those patients, because the parents want these kids, they're there because they want to be desensitized, and it's a frustrating thing when that happens, for sure. I see a lot with egg. The egg desensitizations more so than anything else. I don't know if anybody else has experience with that in their practices. But there are plenty of children that have their atopic dermatitis well managed, and then you start them on oral immunotherapy and they start to flare. Mm-hmm. We see that a lot. We have another question over here, and we're running low on time. So,
great.
Yes.
Yeah, I'm Sean McKnight. I'm from Las Vegas, Nevada. I wondered if any of you have seen some patients that respond initially very, very well to dupilumab, and then after about 9 to 12 months, it's almost like it just stops working. And I mean, we still go back through the same evaluation of them. It's like it's a different medication for them altogether. And then where do you go? Are you going to? Oh, thank you. Are you going to one of the JAK inhibitors from there? Where do you go? And the majority of the ones I'm seeing are younger adults. Often Southeast Asia background, Filipino, those kind of that kind of background.
Yeah, we're not seeing this near as often as we do in psoriasis. It's like a common story in psoriasis where we're cycling through biologics. I would call this a secondary failure, and you would think maybe this is anti-drug antibody. Mm-hmm. We're not seeing it very often with dupilumab, so it's a rare event. I would definitely look into other issues that might be happening. Did the patient get prednisone for an asthma flare? And that kind of destabilized their disease for a while. But if you have a true secondary failure, your options are still wide open. So you could still go to tralokinumab, which is in the same pathway, just because it's the pathway worked at one point. Or you could consider the JAK inhibitors as well. I don't know if you have a different opinion.
Overall, I agree with everything. I have a slightly different experience because my practice has become the dumping ground for every nightmare patient in the region. Yeah. So you'd think like every patient had disastrous side effects or secondary failures with Dupi, when in fact it probably never does in the real world, like very rarely. But I navigate this all the time. When I was first using Dupi in Chicago, like early days, 2017, I just didn't see it. Now I'm getting a lot of these patients who someone else put them on Dupi, maybe, I don't know, 2017, right? And I'm seeing them 3 years later, and they say that it's worn off. Adherence may be an issue that's contributing to anti-drug antibodies, but once the cat's out of the bag, I would then turn to Eric's, concept. I would say, proof of concept type 2 blockade worked in a lot of those cases. You could switch classes. There's evidence from the psoriasis literature, if you sprinkle a little methotrexate on top of that, you can neutralize some of the antidrug antibodies. But what I would say is I'd also be very careful about the course of what you've described, because it can sometimes represent something else, which is a lot of times misdiagnosed cutaneous T-cell lymphoma goes really south when they're put on dupilumab erroneously. So, and what the
Or
law...
if they develop MF. Wow.
Right, which is, that's, I don't, that's like a little even more controversial, but I'll take the definitively clear case where patients had very atypical scenarios in the first place. The biopsy came back spongiotic dermatitis with EOs, but it was like, it always kind of looked like MF. And the other docs even thought about it, but they said, well, the biopsy keeps telling me sponge dermatitis, I'll put them on Dupi. And what they'll often report is in the first month or two, things are going well, and then a switch happens. And then something just goes wrong. And I can't tell you biologically exactly why, but there's many groups around the world trying to understand that now. But it just turns on and it gets worse. So if you see that, if you see worsening, then you get nervous and you'd want to rebiopsy and you might, so I always say, if you even think there's a possibility of CTCL, it's one of the scenarios, again, this is off-label officially, but it's one of the scenarios where I might go more comfortably to a JAK than I would to Dupi, because I have not seen that paradoxical shift with CTCL with the JAK inhibitors, probably because it's a broader mechanism of action. Great. But that's all anecdotal and off-label.
So in addition to ruling out T-cell lymphoma, which obviously is the most important thing, wouldn't you consider patch testing those patients also?
Oh, for sure.
Yes.
For sure.
And I guess I had a patient a year ago that was started on Dupi by a dermatology PI who had scabies.
Right.
Did it work?
I treated the patient for scabies and he got better. No, the Dupi did not work. I guess this concludes our program. Thank you, everybody, for your attendance. Thank you to our esteemed faculty for coming to speak to us today. And thank you to the IEC for sponsoring this wonderful symposium.